and put in this number 86287544. Okay? Yeah, so we're seeing live, lots of thumbs up happening on the screen. Very happy to see that everybody's getting engaged. So this is going to be the common platform for all of us during the rest of today's show. Very simple, go to menti.com, put in the code which you see on the screen. People who want to use the QR code can also do that. Okay, so you can, if those who don't have a net issue can use our hospital Wi-Fi, which is there in your brochure. Otherwise, get into menti.com, put in the code, and so then we are all going to be on the same platform, right? Fantastic, fantastic, everybody's getting on board. Right, good. Yeah, so the code is there, it's going to be there throughout the, this thing on the top of the screen. Okay, so yeah, so just like you've been doing, you can drop in a heart or a like, show some love on this bright Sunday morning. Right, we're getting a lot of love there. Cool. It's only 3 so far. Anyway, no problems, no problems. Okay, so this is one thing. This is another thing. Okay, just to get a grip of how we're going to go through it. Just probably write a word on your mobile if you can see this thing. Just write something what you feel right now. Happy, sad, anything. And yeah, that's great, great. So these are what we are feeling today. So that's fantastic, good. Fantastic to see that everybody is in a good mood. Everybody is in a good mood. Right. Okay, there are some people who have identified that this is a cardiology conference. That's very nice. Curious, excited, poly. Okay, that's good. Right, so everybody's on the same platform. That's fantastic. Right. So we're going to be talking to each other on this platform. As you can see that it's rotating at a randomly very high speed right now. For those who have just joined in, please open your mobiles, join menti.com, which is on the top of the screen. Join menti.com, type in the code which you see on top, 86287544, right? Yeah, you can just get into your mobile. Sorry? Yeah, menti.com. Mohan, anybody? Cool. Yeah, so it's Mohan, front seat, yeah. Yeah, so everybody's got a gist of how it's going to go. That's great. So we're happy to see that we've got 112 responses so far. Very nice, very good. And one person has said meow. That's also interesting. Very good. We've got a lot of creativity happening here. Okay, so now let's try a poll. Is India likely to win the World Cup? Let's see what is the answer for that. So we've got. Okay, so we've got interesting polling happening here. Right. Okay, so there are some pessimists also in the crowd, unfortunately. But nevertheless, optimism reigns, and that's what we need for today and for our country. Okay, the no is coming down and the yes is going up. Very nice, very nice. So I think everybody's got an idea of how we're going to get in. For those who've just joined, menti.com, very simple, menti.com, and use the code which is there on the top of your screen. Our people will be there to help you. Mohan, Venkatesh, everybody just please be around in the front here so that you can see people who are not being able to access. Great, great, fantastic guys. So that's that. So cool. So with that, without further ado, we're going to start. We're going to kick off our conference today. Again, a warm welcome to all of you. It gives me profound pleasure to welcome you all today. Let's have a great academic feast. Over to Devika.
Thank you, sir. Now it's time to start our CME, and I would like to call upon Dr. Bijoy K, Senior Consultant, Interventional Cardiologist, Aster MIMS Calicut, to give a talk about spectrum of disease and evaluation in peripheral arterial disease,
Mohan.
along with
Change.
non-interventional and interventional management. Over to you, sir.
Very warm good morning to everybody. We need warmth, especially in vascular medicine. We not want cold and clammy in vascular medicine. And I'm going to talk on peripheral arterial disease, the spectrum of disease, evaluation and management. The slides, please. Peripheral arterial disease spectrum extends from asymptomatic disease to life-threatening acute limb ischemia. From the asymptomatic disease to life-threatening acute limb ischemia. And I remember when I was doing the first year MD residence in 1998, one of my patients who came to casualty with 2 days of acute limb pain. She was a 65-year-old lady presenting with acute limb pain of 2 days duration. And she was managed as musculoskeletal pain. But the moment she was admitted, we diagnosed that it is an acute occlusion of the iliac arteries. And she was in renal failure. She had cold, clammy right lower limb, but we could not do much. And she succumbed to her illness with multi-organ dysfunction. And after 25 years, what has happened? Let me see what happened to my patient who presented in 2022, April, I think. This is a 48-year-old male who had no comorbidities, who was working in Middle East. He had pain leg of 1 week duration, which progressed to rest pain. He had pain, intense pain at night, and he was sitting up with pain. And he had cold leg discoloration. And with this, he went to the local hospital, and where he was advised expert evaluation, and he came to his native place and came here. On admission here, he had an absence of popliteal and infrapopliteal pulse. And he was seen by the surgeon, and surgical advice was that he requires amputation once the demarcation sets in. Now let us see what has happened to him. And he was referred to cardiology for a possible intervention. This is the angiogram which was taken. You can see that the catheter in the left femoral artery, and you can see that the flow is up to distal left SFA, and the popliteal artery is fully occluded with thrombus. If left alone, his fate would be something like multi-organ dysfunction, amputation, renal failure, and all those things. And today, the science has progressed, medical science has progressed with intervention, and we did thrombus aspiration followed by intra-arterial thrombolysis, and this is the result. And he had a fully established popliteal system with flow up to the ankle you can see in the anterior tibial artery. And today, he ended up with amputation of the distal phalanx of the second toe. Otherwise, his state would be either below knee amputation or above knee amputation, as seen in the second picture. This is not, acute limb ischemia is not confined to lower limb alone. It can happen to the upper limb also. This is a 65-year-old gentleman who had acute onset left arm pain. And you can see the catheter in the left subclavian, and there is a thrombotic occlusion of the left axillary artery with subtle flow into the arm and forearm. This also requires amputation unless promptly intervened. And we did thrombosection followed by balloon dilatation and intra-arterial thrombolysis. And after 2 days of intra-arterial thrombolysis, you can see that the axillary artery is fully recanalized, and it is perfusing the hand as well. And coming to the theoretical part, we all know the classical 6 P's in acute limb ischemia. But many times when we see the patient, we forget these 6 P's of pain, pallor, pulsionosis, pyricothermia, paresthesia, and paralysis. And this is the pointing factor towards acute limb ischemia. In every patient with acute limb pain, all these things should be sought. And coming to the etiology, acute limb ischemia can be due to many causes. In elderly patients, atherosclerosis is one of the most common cause, where there is a narrowed artery. On the top of it, there is a thrombotic occlusion. In younger patients, embolism, medicine and drugs has to be considered. Other things like thrombophilia, which is congenital or acquired like APL syndrome or congenital thrombotic syndromes, systemic disorders, malignancies as paraneoplastic features and rheumatological conditions, and infections, especially COVID times. We used to get so many patients with limb ischemia, unprovoked, as a result of thrombotic complication of COVID. And of course, vascular and anatomic narrowing abnormalities also need to be considered. All these things should be positively searched in case of acute limb ischemia for prevention, for future prevention. And to the approach of acute limb ischemia, this is a complicated slide. Grading of the acute limb ischemia. You can concentrate on the third slide, third thing. It is divided into 3 grades. Third is irreversible, where the patient is profoundly anesthetic with paralysis and there is major tissue loss. And this is an irreversible stage which requires immediate amputation. Whereas grade 1 is there is no sensory loss and there is no motor deficit and there is no immediate threat to the limb. Grade 2 A and B, one is marginally threatened where there is a minimal sensory deficit and limb is salvageable if properly treated. And 2B is immediately threatened where there is mild to moderate motor deficit. And this is also salvageable if promptly revascularized. And revascularization in acute limb ischemia is determined by the degree and extent of ischemia. And you have to assess the viability of the limb rapidly. It is the nerves which is affected fast. The ischemic time is usually about 4 hours, and followed by muscles, which takes about 4 to 6 hours to become ischemic, followed by skin, which takes about 8 to 12 hours. And whenever possible, catheter-based thrombolysis is effective in patients with acute limb ischemia and a salvageable limb. You should give the benefit of a catheter-based thrombolysis in every patient if the limb is viable. And percutaneous mechanical thrombus extraction, that is thrombus aspiration, can be helpful to the lysis. And the surgical options are surgical thrombectomy or bypass. And immediate amputation should be considered as a life-saving procedure in non-salvageable limb. And this is the approach: viable, no neurological deficit, revascularization; viable with neurological deficits also, surgical predominates over endovascular. But if there is no significant motor deficit, you can consider thrombolytic therapy. Where there is an irreversible muscle and limb injury, amputation should be considered for saving life. And these are the thrombolytic agents and doses. I am not going to read all those things. And streptokinase we use here. And the standard recommended dose is 5,000 to 10,000, but doses as much as 50,000 to 1 lakh per unit per hour are used. And the second presentation of peripheral artery disease is chronic limb-threatening ischemia or critical limb ischemia. And this is differentiated by the duration. Whereas acute limb ischemia occurs within 2 weeks, this chronic limb ischemia occurs in the background of peripheral arterial disease with a duration of more than 2 weeks. And there is non-healing ulcers, gangrene, and this is due to peripheral arterial occlusion. And the diagnosis based on the symptoms and signs. And the chronic limb ischemia should be distinguished from the acute limb ischemia by chronicity, more than 2 weeks, and also features of chronic arterial deficiency. And this is a debilitating manifestation. And there is tissue ischemia at rest. The patient will be having a rest pain, which is characterized by nocturnal pain, which awakens and which makes the patient sit. It is due to the ischemia of the nerves. And more than 80 years, 50% of the patients undergoing amputations are due to critical limb ischemia. And the diabetes and smoking increases the risk of amputation. They are 10 times more risk of amputation compared to non-smokers and non-diabetics. And once a critical limb ischemia establishes, within 3 months, 12% of the patient has to undergo amputation, and death is seen within 9% of patients. And coming to the natural history of critical limb ischemia, it happens in 1 to 3% of peripheral arterial disease. If you follow the outcome for 1 year, 1 year, you can see that 25% of the patients are dead due to cardiovascular causes and stroke within 1 year after having a critical limb ischemia. And amputation is seen in 30% patients, and the patients are alive with 2 limbs only in 45%. Only less than half of the patients survives with 2 limbs. And that is the importance. You have to aggressively revascularize the patient. And the treatment in chronic limb-threatening ischemia is a suitable anatomy for endovascular therapy is often present. And the aim of treatment is to restore a pulsatile straight line flow so that the pressure head is transmitted for distal perfusion. And less blood flow is required for viability than to maintain wound healing. The emphasis for treatment of chronic limb ischemia is to promote amputation-free survival and less on long-term patency. Even if you open up the vessel may get closed off, but the amputation can be prevented. And this is the patient with critical limb ischemia. You can see that this is the infrapopliteal vessels. Only the peroneal is seen. Other anterior and posterior tibial arteries are occluded. After the plasty on the left side is the diagram shows, you can see a patent left anterior tibial artery and posterior tibial artery. And the plantar arch is complete. Anterior tibial artery continues as this thing, dorsalis pedis artery. For this patient, the entire posterior tibial artery was ballooned up to the ankle, and the anterior tibial artery was ballooned up to the dorsalis pedis. And a continuous flow is established, and the patient recovered from critical limb ischemia, preventing an amputation or minimizing an amputation. And in patients with critical limb ischemia, below-knee angioplasty is generally preserved for critical limb ischemia. And the long-term limb salvage rate is around 80%. For around 20%, patient need to undergo amputation. But the extent of amputation can be limited if you revascularize the patient. And the best outcomes are seen with focal stenosis, where there is a discrete stenosis, and also when there are less than 5 lesions in a same vessel. Goal is to open up as many arteries as possible. And this is the comparison of bypass surgery versus angioplasty. The study is called BASIL 1, which is published 10 years back. After 6 months, there is no significant difference between amputation-free survival between bypass surgery and endovascular therapy. And there is no difference in quality of life outcomes. And the percutaneous angioplasty is a treatment of choice in critical limb ischemia involving infrapopliteal vessels. And the BASIL 2 was published recently in 2022. And the endovascular treatment is associated with better amputation-free survival. And the third presentation of peripheral artery disease is claudication. Claudication, we all know, is pain, cramp, or sense of fatigue in a group of muscles, usually in the lower extremities, after a sustained exercise, which is relieved promptly by few minutes of rest in standing position. Whereas neurologic claudication needs to, it is relieved by sitting only. And this is the example in a 60-year-old lady who came to our OPD, who was unable to walk because of the buttock and thigh pain. And she was managed as IVDP. And she had absent right femoral pulse and a feeble left femoral pulse. And after non-invasive investigations, angiogram was done, which is shown on the right side. I will explain later regarding treatment and what was done to her. And the common sites of claudication, if it is an aortic or iliac artery occlusion, the buttock and hip vein will be there, radiating to the thighs, which may be mistaken as IVDP. And femoral artery, thigh and calf will be affected. And popliteal artery and distal, calf, ankle, and foot pain will be there with exercise, which is relieved by rest. And peripheral artery disease is not confined to leg alone. It is a systemic manifestation of systemic atherosclerotic disease. The cardiovascular events are increased with myocardial infarction, stroke, limb ischemia, and cardiovascular death also is increased. And they share the same pathogenesis, and they share essentially similar treatment goals. And it is underdiagnosed and undertreated also. And there is an impact of mortality. This is a Kaplan-Meier curve showing patients with large vessel peripheral artery disease. Severe symptomatic peripheral artery disease, only 25% survives more than 10 years. And symptomatic may be around 35%. Even asymptomatic, the longevity is reduced to 50%. And the patients at risk are everybody above 65 years are at risk of peripheral artery disease, and patients with risk factors like smoking, diabetes, hypertension and dyslipidemia between the ages of 50 to 65 years, less than 50 years, diabetic and one another additional atherosclerotic risk. And any patient with coronary disease, carotid disease, subclavian disease, mesenteric artery stenosis or abdominal aortic aneurysms are at risk. And this is to identify prevalence of peripheral artery disease in public population. And according to this Partners Program study, more than 70 years or 50 to 69 years with smoking or diabetes, 29% of patients had peripheral artery disease. And one of the common tests, it is ankle brachial index. This is the diagrammatic representation. The BP is measured by Doppler in the leg as well as in the brachial artery, and ankle pressure by brachial pressure 1 to 1.4 is normal, borderline is 0.91 to 0.99, less than 0.9 is abnormal, more than 1.4 means the non-compressible vessel because of calcification. And resting IBI less than 0.9 corresponds to external leg symptoms. When it becomes less than 0.7, it becomes moderate disease, and less than 0.3, critical limb ischemia, corresponds to non-healing ulcers. And the TO brachial index should be measured whenever there is non-compressible vessels with more than 1.4. ABI also stratifies the cardiovascular risk. When the ABI is less than 0.8, there is a twofold increase in 10-year mortality. And the ABI is 0.4 or less, the mortality increases fourfold. There is no correlation between ABI and the functional capacity. And imaging, we know ultrasound, CT angiogram, MRI angiogram and all, and invasive angiogram is considered whenever revascularization is considered. This is a beautiful picture. CT angiogram with revascularization, reconstruction. You can see that abdominal aorta is occluded, and the reformation is in the common femoral artery. This can be used to plan revascularization and to select the arterial axis. And coming to the management of claudication, we know smoking cessation, supervised exercise and all. And drug treatment, antiplatelet. How much antiplatelet? Single antiplatelet is usually recommended, either aspirin or clopidogrel. It reduces the risk of MI, stroke as well as vascular death. And in asymptomatic also, antiplatelet need to be given. The effectiveness of dual antiplatelet is unknown. And recent Voyager study has shown that the rivaroxaban, the newer anticoagulant, non-vitamin K anticoagulant, 2.5 milligram twice daily after revascularization is useful in preventing MI, stroke, and reducing the mortality in patients after revascularization. Diabetes has to be treated, especially with standards of food care, and to reduce the cardiovascular risk, statins, and blood pressure has to be controlled with antihypertensive. Beta blockers are not contraindicated, as we were taught during MBBS. ACE inhibitors, ARB, and calcium channels are reasonable. And to reduce the claudication, you can use cilostazol. It is a class 1 recommendation. Pentoxifylline is less effective. It is a class 2B recommendation, and clinical effectiveness of pentoxifylline is marginal. And treatment for claudication depends on the severity, mild to moderate only, exercise and drug therapy. If it is severe, you have to localize the lesion. And if it is an aortoiliac disease, the percutaneous intervention has to be considered. If it is a popliteal or infrapopliteal, exercise and drugs and medical therapy. And revascularization is reasonable in lifestyle limiting claudication, not responding to medical treatment. And it is preferred in aortoiliac disease, endovascular treatment. And it is reasonable in femoropopliteal disease. Only selective revascularization in infrapopliteal disease is done with endovascular thing. And this is the patient which I have shown earlier. This patient underwent aortoiliac reconstruction using iliac stents and aortic stent, and this is the final result. The surgical treatment option for this patient would be aortobifemoral bypass, where a bypass and graft is placed between the aorta and both femoral arteries. But even though the patency rate is 80 to 85%, the operative mortality, you can see that it is 5 to 8% compared to endovascular intervention where there is mortality is only 0.1%. And percutaneous interventions are preferred for aortoiliac disease. And this is the angioplasty for SFA in claudication. You can see that critical disease in the left SFA after angioplasty. There is a short segment of occlusion in the left SFA, which is treated with angioplasty and stenting. And these are the surgical treatment in case of peripheral arterial disease. So many things like aortoiliac endarterectomy, aortobifemoral bypass, iliofemoral bypass, and femoral bypass, and lastly axillofemoral, where the axillary artery is bypassed to the femoral artery. And surgical revascularization only should be considered in patients with lifestyle limiting claudication, inadequate response to therapy with an acceptable perioperative risk. All patients should not be subjected to surgery. And autogenous vein graft is preferred to prosthetic material. And the take-home message is this is an underdiagnosed and undertreated disease with high prevalence in the community. It increases the cardiovascular mortality and morbidity. And in acute limb ischemia, the immediate action to establish flow is required, which can save the limb as well as life. The amputation should be considered when the limb is unsalvageable to save the life. And in critical limb ischemia, aggressive efforts to prevent amputation should be done. And the intermittent claudication is treated with exercise, drugs, and selective revascularization. In aortoiliac, you need percutaneous intervention. And asymptomatic, focus on risk factor modification as well as risk reduction. Let me conclude with a statement of Charles Dotter, who is a pioneer in the interventional therapeutics. If a plumber can do it to pipes, we can do it to the blood vessels. Thank you. Thank you for the patient here.
Thank you very much, Dr. Bijoy. So we've got a new designation now, modified royal plumbers right now. It's great. Yeah, so I think there was a fantastic few points of learning there in peripheral arterial disease. Back to our mentee.com, where people who are not willing to open up can actually ask questions. Right, Dr. Bijoy, we got a couple of questions on the board. Single versus dual antiplatelet therapy. So what's your take on single versus dual antiplatelet therapy in PAD?
Single antiplatelet therapy is recommended. There is no evidence for dual antiplatelet therapy unless there is a revascularization. And the recent evidence is Voyager study, which states rivaroxaban 2.5 milligram reduces the morbidity as well as mortality, with reduction in myocardial infarction, stroke, as well as cardiovascular death.
So if you have a stable peripheral arterial disease with claudication, you'll put on a single antiplatelet.
Yeah.
If they've had some intervention, you'll put on dual antiplatelet. For how long, Dr. Bijoy?
For 1 year. For
1 year. Right. Excellent talk, sir. How much acute limb ischemia in your center?
Actually, we don't maintain a data, but definitely maybe 2 to 3 per month we used to get. And during COVID time, we had a clustering of patients with acute limb ischemia, all sorts of patients, upper limb, lower limb, all sorts of patients.
Yeah, right. And what was the cause for the axillary artery occlusion?
The patient actually had chronic atrial fibrillation. It was cardioembolization, and subsequently patient was put on oral anticoagulation. Right.
Okay, so is peripheral angioplasty required in all patients with claudication?
Infrapopliteal, popliteal and infrapopliteal claudication is managed medically most of the time, unless it is limb threatening. In other aortoiliac, it can be done as a first choice, and in femoral arteries, it is a reasonable procedure. All claudications is in need in revascularization.
Correct. So that's an important point. So meaning a lot of people we would like to emphasize, like when you talk about cardiac blocks versus lower limb blocks, there are a lot of patients who we can keep medically very well, but those who patients have limiting claudication and probably critical limb ischemia. Indication for rivaroxaban, Dr. Bijoy, in this subset?
Yeah, we used to give the rivaroxaban for high-risk patients who are at risk of recurrent thrombosis after revascularization to reduce, whenever there is a diffuse disease and the patient keeps on coming with recurrent ischemic syndromes, we used to give rivaroxaban. only in high-risk patients when the bleeding risk is low.
Okay, so that's an interesting question. Okay, will you do a Doppler before an angiogram? So what's the scene? How do you evaluate is what probably they're asking. So which comes, obviously you won't do a Doppler after. So how would you tell them where you'll do a Doppler, where you'll do an angiogram?
Doppler is recommended as on follow-up for surveillance. For acute limb ischemia and critical limb ischemia, I think you should have to proceed with an invasive angiogram. In evaluation of claudication, you can do a Doppler. Otherwise, after procedure, for surveillance only, Doppler is recommended.
But of course, probably in the initial diagnosis, with an acute pain, probably, obviously it comes.
Yeah.
Yes, exactly. So is a CT angiogram required in all cases, or is Doppler enough?
CT angiogram is nowadays not required in all cases. It's mainly for planning, to document the anatomic extent of disease and planning procedures.
Okay. So what about in acute limb ischemia, when not to salvage? What's the risk of reperfusion syndrome?
Whenever there is a muscle damage only, that will be clinically evident as paralysis and severe motor deficit. In those patients, attempting a revascularization is dangerous. Patient can go for metabolic syndrome and can have acute renal failure and multi-organ dysfunction. In that patient, early amputation, whenever the limb is non-viable, amputation is recommended.
Yeah, so I mean, in our clinical practice, when your patients come to us with delayed presentation, so that those people have the risk of these reperfusion. So time is muscle, like we say in cardiology. Time is muscle. As early as possible, within the first 6 hours in an acute limb, if you're able to salvage, you're going to get rid of all of these things. But you have a lot of people, because of lack of early clinical suspicion, comes to us very late, and they end up having gangrene. But nevertheless, I think in our practice, we are able to salvage a lot of, so that at least limit the amount of amputation which can be done. Why stents are not used, or are they used?
The stents are not used because the patents, long-term patency rates of stents in infrapopliteal vessels are not good. Also, at that, in popliteal artery, we cannot use a stent because it is subjected to constant deformation. And king-resistant stents need to be put in popliteal artery.
So what about in femoral lesions, Dr. Bijay?
Femoral artery, you can put a stent if there is no flow-limiting dissection. If the flow is not adequate, then only consider stenting.
Yeah, so I think what we do very often is to achieve a flow, good brisk flow, so that your criticality is taken over. Like for example, you have a gangrene, you have an ulceration, you have a severe rest pain. Because as Dr. Bijoy said, the take-home message is not like in cardiac stents and thing where the long-term patency is to the tune of around 99%. The 5-year patency rates for lower limb angioplasty all across the globe is around 70%. So you have 30% of this thing. So if you're able to create a flow, that's well and good. For embolic evaluation, do all patients need Holter monitoring? Yeah, so I think that's not very much into this thing, but yes, just to see atrial fibrillation. What is the results with the anticoagulation in your experience, sir?
Anticoagulation should be used on patients with chronic atrial fibrillation and indications like high-risk patients, as I mentioned earlier, rivaroxaban.
Okay,
warfarin.
Fantastic. So for the last question, for limb ischemia with infrapopliteal disease, patient with severe pain, what can be done? So this is basically a wrap-up of the question as to critical limb ischemia is what he's referring. What can be done is what he mentioned in the whole talk. We can do a lot of things. So yes, please, you can wrap it up as the last answer for this.
You should attempt angioplasty, establish a straight line flow, at least open up a single vessel without stenosis.
Yes. So medications, assess the anatomy, and try to open up out of the 3 vessels. You have the 3, the tibia, anterotibial, posterior and peroneal. If you're able to achieve at least 1, good, more, even better. Thank you very much, Dr. Bijoy, for that wonderful class.
Thank you very much, sir. And that was about peripheral arterial disease, spectrum evaluation and management. Thank you very much for everyone's interaction also. A young lady is worried her kid has some heart disease. How do you approach? How do you evaluate? Do you need to treat? To answer all these important questions, we welcome Dr. Renu to talk about the pediatric cardiology issues. to discuss this important topic. She is our Senior Pediatric Consultant Cardiologist, Aster MIMS, Calicut. Welcome, ma'am.
I'll introduce her better than Dr. Devika. Dr. Renu ma'am doesn't require any introductions. She's our senior most pediatric cardiologist in the area and chief of pediatric cardiology here, a well-known figure in this part of the world. I invite you, ma'am, for the talk.
Thank you, Salman. Good morning, everyone. So I think everyone would be wondering, what does a pediatric cardiologist have to do, especially in a crowd who's predominantly focused on general medicine and cardiology? I know nobody is pleased to have a child in your OPD because everybody is worried. First thing is, if it's a small child, they don't know how to express what their complaint is. Second is, the parents are very anxious, very cranky parents also. To manage the child and to manage the parents are very, very difficult. So today we'll focus on 3 aspects which you can face in your OPDs, in your outpatient clinics. I'm completely going into 3 case-based scenarios which you can encounter in your OPDs. So as Devika said, a 10-year-old boy was brought by the mother for evaluation of murmur, was detected recently when the child was hospitalized or when was shown to a pediatrician. Asymptomatic as per mother, and the boy complained of mild dyspnea while playing. That too, when asked, mother says, no, he is completely asymptomatic, just the doctor said, idipinu korchu vyathyasam undu, adonnu kanikkan parnu. That's all the mother would say, or the parents would say. And when you probe into the child said, no, when he has minimal limitation, when he plays and he has to probably rest a bit while his other friends are playing. No other significant past history. Now, how do you approach such a patient who is referred as a murmur? I think first and the foremost thing in any complaint is to take a good history and to see, as we have already taken, it's a totally asymptomatic child, no symptom except for that the child says occasionally he has dyspnea. Now, I think you can go back to your basics. Really, this is going back into basics, right? So first, go with the pulse, whether it's a normal volume, low volume or high volume, and then I think current day practice, everybody, what I have seen even in our PGs also, first thing is to take the stent and keep it on the chest. And I think that too should be the last thing to do. Evaluate the history, go for a clinical examination, in the sense, touch the foot of the patient first. Go for the lower limb pulses, which is very, very important, which I'll come into the next scenario. So, examine the pulse, especially all the 4 peripheral pulses, and then examine the chest. You touch the heart, you touch the precordium and see whether there's a cardiomegaly, there's a hyperdynamic precordium or not, and then only you take up the stent. When you take up the stent, you first on S1, S2 normal. Classic writing in all the examination finding, S2, S1, S1, S2 normal. What is S1, what is S2? No explanations. And then no murmur. So we want to specifically focus on what you need to see in this patient. So this child is a relatively well child who doesn't have much of a symptom but definitely has a murmur. So what we have to classify in this child is whether it is just a functional or is it a pathological murmur. So looking at, if all these findings are going to be negative, it is going to be a functional murmur and you can reassure the parents and send them off. Or whether you need to evaluate this child further. I think one important auscultatory finding is the second heart sound. You have to focus on the second heart sound because in a 10 or 11-year-old child, if nobody has picked up a murmur till now, it's likely that it can be an atrial septal defect. So focusing on the second heart sound, if it's a white and fixed split, it always gives an indication it could be an atrial septal defect. But sometimes, when you make the child lie down, there can be variation in the splits. Just focus on, see whether it's just a wide and variable split or a wide and fixed split. Look for any added sounds like an ejection clicks, which will give you a clue because you have got only systolic murmur. Whether it could be a pulmonary stenosis or aortic stenosis, because bicuspid aortic valve is the commonest of the congenital heart disease. So many of them, as they grow up, they can get mild aortic stenosis. So if you can get an ejection click followed by an ejection systolic murmur, and most of the time it could be an aortic stenosis because bicuspid aortic valve is very common. After all this, only concentrate on the murmur. Murmur classified into whether systolic or diastolic. Diastolic murmurs are very rare. So systolic murmurs, whether ejection systolic or pansystolic murmur. One thing you should understand that ejection systolic murmurs are created only in the outflows. So it can be only at the flow across the pulmonary valve or at the aortic valve. A pansystolic murmur, you have only 3 differential diagnoses. It can be either a restrictive ventricular septal defect or a mitral regurgitation or tricuspid regurgitation, nothing else. So that means it narrows our diagnosis to very few things. When it's an ejection systolic murmur, then you have to if you think it is a pathological murmur, you can be only a pulmonary stenosis, aortic stenosis, or it can be just a flow murmur, increased flow murmur because of an ASD. Right, and pansystolic murmur, it's usually restrictive VSD. What about a large VSD? Can a child like this present with a large VSD? Very unlikely. Because in a large VSD, what type of murmur can you hear in a large VSD? Unrestrictive VSD. Can be only ejection systolic murmur, because in a large VSD there is no gradient between the left ventricle and the right ventricle, so there is no because when you get a pansystolic murmur means there is throughout the systole there is a gradient, pressure gradient between the left ventricle and the right ventricle. When it's a large VSD which is unrestrictive, there is no gradient. What you get is an ejection systolic murmur is at the outflow, that is you get a flow murmur across the pulmonary valve. So what you can see here is either a moderate VSD where the QPQS or the pulmonary blood flow is around 1.5 times, or it can be a small VSD, which is a restrictive VSD, which the shunt is less than 1.5. And then other thing which is usually seen as a continuous murmur, which can be missed, and that is a patent ductus arteriosus. There are many other causes of continuous murmur, but let us focus on patent ductus arteriosus. Another one which usually you get referral is the musical, vibratory systolic murmur. Most often it's a functional murmur. Rarely if you focus, and especially if you look at the patient, you feel that the child has a marfanoid habitus, this could be a mitral valve prolapse and a mid-systolic murmur at the apex. That's why I said most of the times a clinical examination itself gives you the clue, because marfanoid habitus is usually missed. Nobody focuses, nobody looks at the children, nobody looks at the hands of the children, at the fingers. So if you focus on that, then you auscultate, means you can know it's likely to be a mitral valve prolapse with a mid-systolic click and a mid-systolic murmur. So these are our possibilities. Now this patient, what could this be? When you look at the X-ray, there is a mild cardiomegaly, and especially it looks the apex is lifted up, so it's mostly a RV type of apex, and you can see that this structure is the main pulmonary artery. So main pulmonary artery is dilated, you have an RV type of apex, and ECG showing RSR dash pattern in V1. Diagnosis is ASD, atrial septal defect, right? So this is the 4-chamber view, which you can see a very good, well centrally located defect, and it's a very tempting to put in a device in. actually earlier ages, we used to send all of them for surgical closures, but now we have become very, very proactive, and I think we send only very few ASDs for surgeries, that is ASDs which do not have adequate rims. Otherwise, most of them we do device closure. But only thing, you have to carefully select your cases for device closure. You can see this is the sheath which is brought in through the IVC, right atrium. The septum almost comes here, and this will be the left atrium, this will be the right atrium. So you cross the defect through with the sheath and you deploy the device. And this part of the device is in the left atrium, and this is in the right atrium. And one very good thing about these interventions are that the children are back playing by the next day itself. They can go to school within the next few days. Only things they have to be on antiplatelet, that is aspirin, for the next 6 months, because we wait for the endothelium to cover the device, because this devices are made up of nitinol, that is nickel, an alloy of nickel and titanium. So to prevent thrombus formation, you put them on antiplatelets for 6 months. And also you advise them infective endocarditis prophylaxis for 6 months till this endothelium covers this. Now what about VSD? I said if it is if you are listening to a pansystolic murmur, it can be either a moderate VSD or a small VSD, and you have to moderate VSDs means you have to send them for surgery or device depending on the anatomy. Restrictive or very small VSD with no chamber dilatation, you don't have to close them, because their only risk, most common risk, what risk they can have is infective endocarditis, and only thing is you have to follow them up for other complications like development of aortic regurgitation or development of any jet lesion like which hits on the RV and development of a pulmonary stenosis, infundibulary pulmonary stenosis. So this is a VSD which we have done, VSD device closure. You can see the LV angiogram and you can see the perimembranous VSD, and this is the deployment of the VSD device. This is through the retrograde approach through the LV, that is through the aorta. We have come into the LV and across the VSD, and we are deploying the device here. And this is, you can doing an LV angiogram after deploying the device to make sure that the device is well in position, there is no residual flows, and you have not damaged the aortic valve. But you have to carefully select. I think selection is beyond this talk, so I'll not talk about it. And what about device closure of the PDA? PDAs actually we don't send almost I can say 99% of the PDAs are now closed by devices only. Only in preterms or smaller children with large ducts, unrestrictive ducts, and also with unfavorable anatomy, we send them for surgery. Otherwise, we send all of them for device closure. And you can see this conical one is a PDA, and you can see the device being deployed here. This is the PDA device where you have an aortic disc, larger aortic disc, which sits inside the aorta, and you can see it being deployed. So that is regarding murmur. Next is a 12-year-old boy with headache, detected to have a murmur, so was referred to you, and BP recording revealed hypertension, and the child has been on, then the patient is seen by multiple persons. The child is being put on multiple medications, but the hypertension is completely uncontrolled. This is not an imaginative scenario. We have gone through many such patients. That's why I'm stressing on the scenario. Not controlled on multiple medications and has exertional dyspnea while playing, and when probed into has some leg pain. Examination, pulse is low volume or even absent lower limb pulses. This is a key point where you should examine in every patient, every children especially, you see, even including we stress it on neonates also, because we miss even neonatal coarctation, which can be life-threatening. And an ejection systolic murmur of the left upper sternal border, and some of them may have a continuous murmur at the back indicating collaterals. So diagnosis is coarctation of aorta. How do you deal with coarctation of aorta? In all neonates, neonatal coarctations, the treatment is surgery. Intervention like balloon angioplasty is indicated in patients who develop recoarctation or in slightly grown up children with discrete coarctation, and stenting only for children who are more than 25 kg. This is one of the patients who underwent balloon dilatation. You can see the coarctation, discrete coarctation, and this is how you go for the balloon dilatation. And in a 15-year-old child, we have gone for, this is stenting of the, you can see the severe coarctation, you can see a stenting. But the issue with the long-standing coarctation is that you can correct the anatomy, but the residual hypertension remains, and they have to be on long-term drugs, medications. So that is the importance of monitoring the lower limb pulses and looking for hypertension. I think at least in our Indian Academy of Pediatrics also recommendations, we advise them to check the BP at least once in 6 months in your BC. Even if it's a BC OPD, ask your attendant to check the BP at least once. Adult, I know everybody will do it, but in pediatric practice, please check the BP at least once. Now this is a 11-year-old boy. Very common thing that you face in your practice is chest pain. So around 6% of our practice, 6% of the patients are referred with chest pain, because parents really panic because of chest pain because of fear of myocardial infarction or ischemia. So this boy, 11-year-old boy, who had a history of prolonged febrile illness with elevated counts and acute phase reactants, few weeks back needing hospitalization, and that time there was a history of febrile illness in the family, and now the patient presented few weeks later with history of central chest pain and epigastric discomfort, mild breathlessness. What are the things you can approach? How do you approach this patient? So Then you look at examine the patient. If the patient is very comfortable, there is no distress, no tachycardia, no tachypnea, the heart sounds are normally heard, there is no muffling, no murmur or rub. ECG, definitely you have to take for and go for an ECG, take the ECG, it's normal, and it's most commonly, this happens around 95%, they're all non-cardiac chest pain, you can just reassure them. But the most important treatment probably here is counseling. You have to sit with the patients, you have to sit with the parents, you have to take a detailed history and make sure that it is a musculoskeletal pain or other pain, and you have to rule out a cardiac cause, because I get at least one patient with chest pain in every OPD. So this is very common thing. And the other one, another scenario is the child is restless, has tachycardia, has positional pain. When auscultated, you have a pericardial rub. And echo showed a mild myocardial LV ventricular dysfunction. This is also another common scenario where you get myopericarditis. You are not sure whether there's a coronary involvement or not. It's very difficult because they will have ST changes also. Along with that, there is some LV dysfunction. This is also a common scenario, not very common, especially this is seen especially when there is a viral fever outbreak. So in pericarditis, I think this is all of you are very familiar with it. The stage 1 ECG changes are, stage 1 is widespread ST elevation with PR depression with reciprocal changes in AVR. This is usually seen in the first 2 weeks of the illness, and by stage 2, that is normalization of the ST changes with generalized T wave flattening in the 1 to 3 weeks. And stage 3, there is flattened T waves, they become inverted. And then within few weeks, they return to normal. But having said this, only 50% of them follow through these classical stages, and many of them do not follow this pattern. Management is usually, if there is only pericarditis, it is NSAIDs or steroids. If it is myocardium is also involved, you may have to put the patient on inotropes. This is a classical ECG where you can see the ST elevation and you can see the PR depression here. This I don't think you would have met with this scenario, but actually this is becoming very common because of the especially post-COVID. The child is restless, has tachypnea, tachycardia, elevated JVP, tender hepatomegaly, cardiomegaly with an LVS3, and echo showed LV dysfunction with dilated coronaries. Most of you know what you have gone through, either a MISC or a Kawasaki disease. So this is a patient, child. This was actually even a smaller child. You can see the coronary aneurysms. See, huge aneurysms of the coronaries. This is the CT, you can see this. This is the right coronary artery and this is the left coronary artery. You can see the LAD, right? You can see the normal coronary, distal coronaries. And this was how the patient presented to us. You can see a thrombus inside the RC aneurysm and in the LAD also, because this was a patient whom the parents actually were not very compliant with the medications and developed a significant thrombus of the aneurysms and severe LV dysfunction. You can see with the thrombus even on a 4-chamber view. And this child actually this patient presented in pediatric surgery with epigastric pain, and they decided they were actually evaluating for appendicitis. And just because this patient was seen by us earlier, they sent us for an echo. We see that the child was very orthopneic, couldn't lie down. And the moment you put in, actually the child had already infarcted, you could see a severe LV dysfunction. This was the ECG indicating an infarct. You can see the giant aneurysms. This is an RC injection which shows a giant aneurysm. And this is LMCA. Huge aneurysm. You can see the aneurysms here also. See. This patient actually, when it was very bad with poor LV, we had to take her for CABG. This child was just 3 years old. Didn't make it. And this is a patient who presented recently actually. I just put the scenario to bring this into the picture. This is a patient who got discharged yesterday. He was an 11-year-old boy who was treated as MISC and was given steroids. Echo reported, everybody has reported as normal. No coronary dilatation. He was just treated with steroids. He presented again because he had some discomfort, again presented. Then actually they detected the aneurysms. And by that time, the damage has already been done. You can see the massive aneurysms in the LED. You can see the circumflex, which is normal. You can see the RCA, which has massive aneurysms, and they are prone for thrombosis. And so what I meant to say is that these patients who have undetected MISC or Kawasaki happening earlier, especially post-COVID era, so when they present with chest pain, please do not ignore it as a musculoskeletal pain in the first context itself. Just go back, take a bit of time, go back into the history, whether there is a significant relevant history, examine the patient, and if needed, go for an ECG as well as echo before you discharge the patient as normal. So this is a few words about Kawasaki disease, an acute self-limiting systemic vasculitis which has a predilection for coronary arteries and a potential for aneurysm formation. This was earlier actually, it was more common in younger children, but now in the past few years, we have seen so many grown-up children, especially 10, 11, 12 years old, even 15-year-old who has presented with coronary aneurysms. And here the diagnosis based on the recognition of a temporal sequence of clinical features. I'm not going to the details of this. The major issues are of Kawasaki disease is coronary artery lesions, and it develops in about 15 to 20% of untreated patients or patients who are treated late. Involvement is maximal within the first 6 to 8 weeks. Prevalence is reduced to 1 to 2%, than 15 to 2% if you give IVIG, intravenous immunoglobulin, within the first 10 days of the onset. Late presentation, very high risk for coronary aneurysms. And the treatment is predominantly high dose IVIG. This is the preliminary treatment, and then go for aspirin and the anti-inflammatory dose followed by antiplatelet dose till the coronaries are normal. You continue, keep them on long-term follow-up. So going for the take-home messages, detailed history, systematic examination helps to arrive at a diagnosis. In most of the times, you can at least come to a clinical diagnosis, and do not forget to check the lower limb pulses, especially in patients with hypertension. Chest X-ray and ECG have added value in the diagnosis, though in it nowadays, the first thing for a cardiologist is to put a probe on the chest. Before that, definitely go for a systemic evaluation, chest X-ray and ECG. Never put a echo probe on your chest before you have taken a proper history and a detailed clinical examination. And prompt diagnosis of a CHD and timely referral for intervention and surgery. Majority of the cases of chest pain in children are non-cardiac, but beware of the warning signs. Thank you.
Thank you very much, Renu ma'am. Fantastic talk and fantastic take-home messages. I think that's a very important, one of the take-home messages which he said is to, while examining, put one hand on the dorsalis pedis. I think that's a grand clinical take-home message, which is one thing which most of us may not be doing when you're examining a child or even an adult. That's a very important thing. So to get the ball rolling, let's have our questions. What do you want to ask Dr. Renu regarding adult or pediatric congenital heart disease? So the first question on board, we have, what are the indications of steroids in pericarditis?
Actually, if it's a massive pericardium, mostly initially we start with NSAIDs only. If it's not responding, we go for steroids. As such, no definite indication for pericardium steroids as such if it is associated with other disorders like like rheumatoid arthritis, systemic GRA or anything, you will have to go for steroids.
So what about the viral ones?
Viral ones, usually if it is, you can manage with NSAIDs.
NSAIDs.
Yeah.
Aspirin's good. So there is some
tuberculous pericarditis, we go for steroids.
We go for steroids to prevent constriction, which is a very morbid complication of tuberculous pericarditis, is chronic constrictive pericarditis. In adults, when we have viral pericarditis, if they have very recurrent pain, we do have data to give colchicine, and so that's
helps to reduce the pain also.
Yes, anti-inflammatory. Yeah. So what about early IVIG in MISC syndrome?
Yeah, MISC syndrome we treat with IVIG as well as steroids.
Yeah.
Once diagnosed, we go for both.
Yeah, and for those who are not aware of MISC, you could just expand it for them.
Multisystem inflammatory disorder post-COVID.
In children, yeah.
MISC in neonates, MISC in children, MISC in adults.
Yeah.
Can have different presentations. Even neonates, we have had neonates also with MISC.
Right. Okay, so what are the points which can substantiate a benign or flow murmur in adolescents?
Yeah.
You hear a murmur in adolescents, what makes you think that it's a flow murmur?
First thing is No symptoms. It's been a asymptomatic patient, no symptoms. As you said, clinical examination always help you to differentiate it, and definitely the quality of the murmur. If you listen to few innocent murmurs, you know this is an innocent murmur because they have the musical quality.
So you got to keep auscultating.
Yeah.
Keep listening.
Definitely.
Keep listening to the heart.
Keep listening to the
Yeah.
hearts.
Right.
Listen to your heart and others' hearts also. So that
Yeah. It's very true. I mean, in cardiology, whenever we teach our residents, there are a lot of our ears don't tend to listen what we don't know what to listen.
Absolutely.
So there's that S1, S2 normal, and I try to actually sit and try to listen what murmur you're trying to hear. Good. So what are the indications of surgical closure for ASD in children?
Right. So first is indication for closure of any defect is when the shunt is significant, that when there is a more than 2:1 shunt, that is the pulmonary blood flow is more than twice that of systemic blood flow. And indication
So
for
how do we know that, ma'am?
QPQS
What
clinically.
what is 2:1?
So clinically, it's actually QPQS is calculated by cath, but we can do it even clinically. How do you assess a large shunt? That is a more than 2:1 shunt is if you get an additional flomer. For in an ASD, you get what you expect is cardiomegaly, you get a wide fixed S2 split. Along with that, you get ejection systolic murmur that is across the pulmonary, that is RVOT. But if you get an additional flow murmur across the tricuspid valve in a ASD, that indicates that the flow is significant, that is a more than 2:1 shunt. So you can quantify the shunt even by your clinical examination.
So if there is cardiomegaly, it's a big shunt.
Absolutely.
Take home? Yeah. So do all ASDs require closure? What is the ideal age? What is the ideal age?
Ideal age for closure is actually preschool age before sending them off to school. But saying, when I say that also, there are around 5% of children who require ASD closure within the first year of life. That is when they are significantly symptomatic, in refractory heart failure, even with an ASD, and they have life-threatening pneumonias. We close them even before 1 year of age.
So you can do that before 1 year of age
Yeah,
also.
but before 1 year, actually we send them for surgical closure.
So we diagnose in ASD at 25 years of age.
Definitely.
What do?
Yeah,
We should still close.
Yeah, definitely.
Yes.
Still
So
close if there is a volume overload.
Yes. At any age, we have a lot of asymptomatic patients who are incidentally detected in our OPDs. You have volume overload, and if they've not developed pH, so we think about closure.
Especially they present mostly, many of them present during pregnancy.
Right.
The volume overload.
So what is the advice to the mother of a child with tetralogy of fallow before tooth extraction or a dental procedure?
Okay, fine. So whether it's a tetralogy or any lesion which has a residual restrictive jet, that is a jet which has a pressure gradient, or any child who has underwent an intervention with a residual lesion, you have to give them infective endocarditis prophylaxis. Many of the dental procedures, they require only amoxicillin. You can give them oral amoxicillin 50 milligram per kilogram 1 hour prior to the procedure.
Great. So that is for those who don't understand infective endocarditis prophylaxis in dental procedure. So it's like you have a focus of infection in your dental caries. The moment you create an incision in the mucosal membrane, that is when you get in contact with the bloodstream, and that is the nidus for initiating bacteremia. And so then you create an antibiotic bloodstream so that you prevent bacteremia and prevent a bacteria from sitting on one of your congenitally abnormal valves. That's the concept for IE prophylaxis anywhere in valvular disease, right? So how often does Kawasaki present with classical symptoms like strawberry tongue? Does it present like a normal flu, or how does it look like?
Actually, now the classical presentation actually has come down. Classical presentation will be high-grade fever for around 5 days. Along with that, there is conjunctival congestion and non-purulent conjunctivitis. Not purulent, it's non-purulent conjunctivitis, and you have significant erythema of the lips, along with even denudation of the lips and even the tongue, oral cavity, and then you have non-tender lymphadenopathy and rashes. So these are the classical signs of Kawasaki disease. This usually happens in the first week and not responding to paracetamol or analgesics, and the next week they come to us. You have, when you examine the blood, you have elevated platelet count. Second week, by second week, get an elevated thrombocytosis you get, and if you have an associated leukocytosis and severe anemia with high-flying acute phase reactants like CRP and ESR, that indicates that you are at risk for coronary aneurysms.
So any signs or symptoms of coronary aneurysms or specific ECG changes for that?
No, coronary aneurysms will not have an ECG change. Only once they are
Thrombosed or
got
something.
thrombosed, you get the change.
So, so what is their natural history? What happens to those huge guys which you saw, those huge aneurysms?
They will not rupture because they're very thick and fibrosed. What happens is they're at high risk of thrombosis. If a smaller dilatation, just a dilatation alone, they regress. But if such giant aneurysm, they never regress, and the risk is actually, once they have stasis, there is a risk of the coronary distal to the aneurysms can get occluded.
Okay,
They get
so
thrombosed.
great, fantastic. We'll go for the last question. Duchenne's muscular atrophy with LV dysfunction. What are the probable causes, madam?
No, LV dysfunction is a part of Duchenne muscular dystrophy. Actually, we follow them up. We have muscular dystrophy clinics actually. Every Friday, almost monthly, twice, we have a SMILU's clinic. We get so many patients, very distressing to see them. And most of them develop LV dysfunction as a part of the disease.
Okay, fantastic. Okay, one more question. How to approach a child with chest pain? So you said that a lot of people, 6% comes with chest pain. What do you do for them?
Yeah, first thing,
From a
sit
quick
with them.
general practice
sit with them
point
and
of view.
talk to them, and just a detailed history of the chest pain. What is the type of chest pain? That usually gives you the clue. Most of them have a catching chest pain, or most of them have a pricking type of chest pain, and very, very rarely does a comfortable child have a significant pathology. Most of the time, and many of the times, it is due to the improper positioning of the bag, their school bag, or the postures, because nowadays with the mobile and the tabs, they sit in all sides of postures, they sit and see the TV. So that itself results in their chest pain, straining them. Just talk to them, reassure them, clinically examine them, take an ECG, that would be enough for most of them.
Right, fantastic. Thank you very much, Dr. Renu, for that fantastic talk and for those wrap-up on general cardiology.
Thank you.
Thank you very much.
Thank you very much, dear ma'am. That was a very informative talk about the common cardiac issues in children. Moving on, now I would like to call Dr. Salman, our host, HOD Senior Consultant, for his talk on approach to the diagnosis of STEMI and how to tackle and manage them. Over to you, sir.
Hi, good to see me back again. We have a small change in schedule. Dr. Praveen, who was supposed to be talking, had a small travel issue. He'll be coming in half an hour, so you'll have to see me before him. Right, so, okay, I will talk on this one first and go to the next talk later. Okay, so this is a talk in the brochure by Dr. Sudeep Koshi. Unfortunately, he also had a small medical emergency for which he's actually admitted here. So for which I'm going to be taking over. So this talk is, I think, at number 5 or so, about when we have a STEMI or an acute coronary syndrome, what should we do? How should we approach? Those are the things which I'd like to discuss here. Right. So let's see if this is working. Right. So we know acute coronary syndromes are ST elevation syndromes and non-ST elevation syndromes, right? So, oops. Right, so ST elevation, we all know that's which we call as STEMIs, and those which are not coming under those acute coronary syndromes, non-ST elevation. So under that we have 2. There's unstable angina and STEMI. So it's very important that everybody's on the same platform here, that when you talk about acute coronary syndromes, these are the 3 things which you're talking about: unstable angina, STEMI, or non-ST elevation MI, and ST elevation MI. Right, so obviously here you have ST elevation MI, it's a medical emergency, everybody's running, the ambulance is coming, you're going, doing some revascularization. Here you can either have, you have pain, you have ST depression or T-wave inversions with the typical pain syndromes. The difference between unstable angina and non-ST elevation, we all know that it is troponin positivity. So patient has typical pain. So this is the most important feature here, I would say, is for unstable angina is, I would think, out of all 3 is the most important. Why? Because I have a patient, and we always come across this in clinical practice. You have a patient with severe chest pain, crushing chest pain, okay? And then you come to the ED and the ECG is normal. Then what do? We do a troponin. Troponin's normal. Then what do? Go back home with Pantocid 40 milligram twice daily. Oh, that's very dangerous, man. So that is unstable angina. So if you're able to understand that this patient has got TPOs, this is a clinical thing. You're not going to see it in EC, you're not going to see in your troponin. If you are seeing the central heaviness which is crushing and with exertion or whatever, and it's just started today, you got to think of the possibility of unstable angina. Keep the patient under observation, and then that's a very important take-home message that I'd like to say. The coronary anatomy is not very important. We have the LAD, RCA. I'm going to talk about this in the coming slides. We all know we have the right coronary tree, the left coronary, which has got the left anti-descending and the circumflex artery. This is the left main. Circumflex LADR. It's not very important from a general practice point of view, but then a lot of people talk about localizing and all that. Personally, I think it's not very important from your perspective, but yes, it's good to know what's happening inside the coronary anatomy. So we all know the basic, I'm not going to get into this too much, ST segment depression, but you should know that this is an upsloping ST depression. This is a downsloping. It's very important for TMT, which I'll talk in the next slide, the next talk rather. And this is a flat ST depression. These two are pretty important to know, right? And these are all the different types of ST depressions, which I'll get to into the next one. So what is a significant T-wave inversion? Okay, it should be a little deep, okay? And at least in two contiguous leads, which are of the same territory. And if it is dynamic, then it's very important. For example, it's upright now, and that patient, which I said earlier, 3 hours later, it's gone for an inversion. That seals the diagnosis of unstable angina or non-aspiration MI. So that's important. So observing that patient for serial changes is extremely important. Important take-home message. You have a T-wave inversion in lead 3 alone. I think I showed that in one of the ECGs in the group. It's a normal finding. You have T-wave inversions in AVR, it's a normal finding. You have T-wave inversions V1, it's a normal finding. So you have an isolated T-wave inversions over here is a normal finding, right? Other causes are, like what I said in the group was, look at this one. This asymmetric T-wave inversion, this is seen in LVH, okay? And this one, we are sort of symmetric. The first one is sort of symmetric is the one which you're going to see in ischemia. Okay, you're going to see a lot of LVHs in your clinical practice, systemic hypertension LVH. They're going to have these tall voltages. So look for those tall voltages and asymmetric. So that's LVH. So you're not going to say lateral ischemia, you're not going to say lateral MI. If the patient has chest pain, you've got to do another test like troponin to confirm. But that is another very common cause of T-wave inversion. Okay, so let's see a few syndromes what we have. Young man with crushing chest pain. Okay, this comes with the ECG. Having a lot of chest pains. What do we do? So we look at the ECG and try to understand what's happening. Let me get this stick up. Yes. Yeah. So we're seeing these tall guys here. Okay. So what could it be? Hyperacute T waves maybe. Hyperkalemia. Normal ECG. Could be anything. But he's having crushing chest pain. You cannot say bye-bye and Pantocid anyway. So he's really in agony. And so you look at these tall T waves, you're sort of thinking that it could be. But like Dr. Sandeep mentioned in the group, for all of those who are in the group, look at those reciprocal guys sitting there, you know? So that's very important. So this is hyperacute T waves. So you're going to sit with the patient and probably think of the anterior wall MI. Why you think of the anterior wall MI is look at those reciprocal changes over there. So evolution of MI, how it starts off, we all have learned it, but it's always good to know in the first few minutes, you're going to start getting up the hyperacute T waves. Then comes the ST elevation, the next hour, and then within 6 hours, the T wave starts to invert. So if you've seen a T wave inverting in STMI, you think that at least 6 hours have passed, you're missing the bus, you got to up your game, and then comes the Q wave, the R wave starts to come down within the next few days, which is again the evolved MI. Now somebody's asking me how I'll differentiate between a hyperacute T wave versus hyperkalemia. Okay, so this is what we saw earlier. So you have a tall T wave, it's a little broadish, it's quite difficult sometimes, a little broadish, whereas your hyperkalemia is also tall, but it's a little narrow and it's pointed, right? And so that's symmetric. And then you have certain normal people who have a little bit tallish waves, who have big voltages. They will usually have asymmetric waves like this. So a little bit experience in this, but with the clinical scenario is what is going to get you there, right? So this patient which I said, look at those, if you see those reciprocal changes, you're confirming a diagnosis of MI, and then do your loading and send for revascularization as soon as possible. Okay, this is a 65-year-old guy who had chest pain and severe hypotension and is coming to you, and what do you see here? So you're seeing here at the first glance, you're seeing some problems here. I'm seeing some ST here, I'm seeing some ST here, some ST here also. Oh no, there's some ST here also. There's some ST here also. There's ST here also, ST here. So there's a lot of ST depression happening here. So what am I thinking? But then there's ST elevation AVR. So this patient with a lot of global ST depression with an AVR ST elevation, it's sort of an ominous kind of thing, meaning there are a lot of vascular territories involved, meaning you're having probably a triple vessel disease pattern or probably a left main disease. Left main disease supplies a large volume of myocardium, and that's a little problem. So you have widespread horizontal depression, ST elevations in AVR, ominous sign. This is another patient. So when you're seeing these ST depression, sometimes we tend to look at these and say lateral ST depression. Have a look closely. Here also there's depression. AVR is getting elevated here. Look at your one AVL, the inferior leads also a little bit. Here is a little isoelectric. So when you have global ST depression with an AVR ST elevation, you should be careful. Okay. Another scenario, 50-year-old man, he comes at 1 a.m. with chest pain lasting 10 minutes. 1 hour back, presented to the ED. Right now, he is pain-free. Okay, so he's saying he had pain at home. He comes to the ED, he's okay. But his wife pushed him. Let's go have a check. So the important point here is what? Whenever patients come at 1 a.m., don't give Pantocid and send him back. Because patients very well know that they have a true problem. It's a very common problem in triaging patients in casualties in EDs. Patients who come at 1 a.m., give them respect. Give them respect. Why they have come from their home at 1 a.m., there must be something wrong. Sir William Osler said, listen to your patient. He's telling you his diagnosis. But we listen to troponin. Negative? Send with Pantocid. It's a very big problem. So William Osler said, listen to him, he's telling you I've got a chest pain, listen to him, give him respect. So your ECG is saying, okay, yeah, it's not too bad, there's some T-wave inversion here, probably it's okay, forget it, not a problem. He's pain-free now, so what should I do? Okay, should I call the cardiologist? Okay, then what happens? At 1:30 a.m., half an hour later, because we anyway thought we'll shift him to ICU, he gets profuse chest pain and he gets your hyperacute T waves and a progressive anterior wall STEMI. So this is basically what we call as Wellens syndrome, whereby, a patient having biphasic T-wave inversions in the anterior leads or T-wave inversions in the anterior leads is suggestive of an impending anterior wall ST elevation MI, which is a very, very significant thing. So you have a Sir Wellens, Heinz Wellens, a professor from Netherlands, actually described this syndrome saying that the patient had pain at home and presents to you pain-free with that biphasic T wave. That's what you need to catch. So you don't say that he doesn't have anything, you observe him, and the patient, within the next 1 day or so, he is going to develop an anterior wall MI. So this is very important, and it's very specific for a critical stenosis of the proximal left anterior descending artery. And the key point is that he may be pain-free at that. So Wellens syndrome is exactly described for that particular thing, that he may be pain-free at that particular point of time. So very high risk for extensive anterior wall MI. That's the patient which we had. Look at that. So what you can see at the arrow is where actually the LED was occluded by the time we took him up to the cath lab, and we sent him took him up for revascularization, and that's his beautiful LED which is recanalized, saving his myocardium. Interesting. Okay, back to scenarios. Young 32-year-old guy, typical crushing chest pain, right? So what are you seeing here? You're seeing some ST elevation, okay, it looks simple. I'm seeing some ST elevation there and ST elevation here. This is probably simple. This is anterior wall over there, so the lateral also is there, so you call it anterolateral STEMI. So it's very straightforward. Straightforward for us to diagnose, but very bad for the patient. He's only a young 32-year-old chap, poor fellow. So that is that. So anterolateral STEMI, identify, give your loading doses, do an echocardiogram, send for early revascularization, thrombolysis, whichever is available. Right. So what about this guy? He's got 50-year-old smoker, diaphoresis, chest heaviness. What are we seeing here? We're seeing some elevations over here, ST elevations in V1, V2, V3, V4, V5. Oh, but there are some elevations in 2, 3, AVF also. So that's interesting. So why does God do this? you get an anterior wall MI and an inferior wall MI. That's a problem. Anterior plus inferior MI. Interesting problem. Right. So it does happen sometimes. It's basically the ECG just reflects the area of myocardium. So this is the angiogram which the patient had. If you look at the heart like that, so this is the LAD, okay, which supplies the anterior wall. This is the anterior wall. This is the inferior wall. So inferior wall is usually supplied by the right coronary artery. So the right coronary artery comes like this and gives like that over here. And this is the inferior wall. Sometimes the LAD is congenitally very long, which we call as a wraparound LAD. It goes all the way winding like this and goes to the inferior wall also. So when you have an occlusion over here, the anterior wall plus the inferior wall becomes ischemic and gets you the thing. So that's all. So that's that. So it's not a big deal, but you cannot have an inferior plus anterior. So it's always the anterior and inferior because the RCA cannot go and wrap around the LAD. It doesn't usually happen. So it's basically an anterior wall MI. It's a larger myocardium. So like we say anterolateral. So it's something like that. So not about this thing. So here, this is another person with chest pain. What are we seeing here? We're seeing some ST elevations here, but what's the difference? What's the difference here? We're seeing that important part to note is that you're seeing some positivity in V1. Positive waves in V1 means there is something happening there. This is usually RBBB. We discussed this in the group. When we see a positive wave in R wave there and a broad deep S wave here, that is RBBB. But here, in this anterior wall MI situation, if his patient is developing RBBB, which is a QRBB pattern, this means that the first septal artery is involved. That is the branch supplying the right bundle is way proximal in the LAD, and therefore that has got a grave prognosis. Grave prognosis because the large volume of myocardium is lost. So here what happens is this is the LAD. So this is the first septal branch. So this supplies the right bundle conduction system here. So the occlusion has to be somewhere here for this to happen. So that means this whole thing is, that's why it carries a grave prognosis. So large volumes. You can have an anterior wall MI here also. You can have an anterior wall MI here also. So here at least these are all spared. But once you have QRBB means this also is involved. So that means you have a large volume of infarction happening. Just some nomenclature. Septal is V1, V2, V2 to V5 is anterior. Lateral, as I said, is V5, V6, and one AVL. And extensive anterior means all of these are involved. That is V1 to V5, V6, and even the lateral leads. So this is what we mean. Okay, let's see a 60-year-old guy with the loss of consciousness, profuse sweating. You can see you have ST elevations in the inferior leads. We know that it's a inferior ST elevation MI. We all know that very well. So now once he gets to ICCU, what's happening here? What are you seeing here? There is some slowness happening. The ST elevation is there, but you should try to identify that it's getting slow. There is bradycardia happening. Once you're seeing there is bradycardia, you see what is the type of bradycardia. You're seeing the P waves over here, which are not getting conducted well, and this is basically complete heart block, escape rate of only 35. So inferior wall MI, look for bradycardia. That's another emergency. You need to give your atropine, your deraphyllin, put in a temporary pacemaker, and revascularize or thrombolize as soon as possible. So that's one thing you should look for, bradycardia in inferior STEMI. What else you look for in inferior STEMIs? This is also another inferior STEMI. Look for these are all basic stuff. I'm just going to run through that. You look for your right ventricular leads. Look for RVMI here. RV infarction, subtle elevation in the V4R. Also, you can see it in V1, right? What else to look for in inferior wall MI? You look for posterior wall. Okay, everybody knows that. That is seen like this, V2, V3, you have ST depression, positive R, positive T. So this is the mirror image of a posterior wall look, what you're going to see. So this is posterior wall, this is how a posterior wall. So keep this in your picture in your brain, this is how a posterior wall MI looks. All right. So another syndrome, 50-year-old, this is a very important thing which one might not recognize. 50-year-old guy with chest pain, you're having this. This is something looking like a hyperacute, right? But I want you to focus on this particular pattern. This is basically the de-winter T wave, okay? So basically how it looks is that an upsloping ST depression, a peaked anterior T wave, and a little bit of ST elevation AVR. I'll show that to you again. Like this. It's a very funny looking wave. You get to see it in 1 to 2% of STEMIs situations. This particular look is actually an anterior STEMI equivalent. So actually basically the proximal LED is occluded. For some weird reason, the depolarization happens like this, and this is how it looks. This is a de-Winter wave, and it actually signifies LED occlusion. And this you have. It may look like a posterior STEMI, but it's not posterior. You sort of see like this and going up like that. This is a sharp upslope, which you see is the de-Winter wave. Immediate reperfusion is required. 44-year-old smoker with chest pain. Again, what are we seeing here? This is an important syndrome to understand. What are we seeing here? ST elevation here, ST elevation here. So we look one and AVL. So look at the anterior leads, not much. So this is a lateral wall. So what we call as high lateral. And again, to confirm that, you can see that the 3 and AVF is ST depressed. So that's basically a diagonal occlusion. This is the LAD, the lateral part of the ventricle. When this gets occluded, this is called a high lateral. So the first diagonal, if you get, it's called a high lateral. It's okay, no problem. I think this is the last slide. A 52-year-old guy who's got, came for insurance checkup, and the technician said he's got an MI and came to us. What is this? So this is basically left bundle branch block. When you see the M pattern in the V5, V6, and 1 AVL, basically this is LBBB. These patients can have ST elevation over here, but that's a mimic which Dr. Sandeep will be talking soon, and that is actually not MI, and you have the Garbosa's criteria for us to how to diagnose in that is that basically in LBBB, once you have these wide here, it should supposed to be going downwards. This is the normal STD change. But if it goes upwards, that is concordantly going up, that's a problem. That can be this thing. Or if that elevation is more than 5 mm, which you saw in V1, V2, that is also an indicator of LBBB. So that is my this thing. So one, I may have been a little bit fast, but but we just have to keep looking, keep practicing, and understand the basic concepts of how to approach ischemia infarction syndromes. Thank you very much. Right, so I'll moderate my own session. Poor me. So if anybody has any questions, they're free to ask before we wrap up for tea. So there are a number of questions which, just put on my other one, yeah. There are a number of things which one could probably ask in MI because it's something which we see day to day. So what are the criteria for hyperacute T waves? Yeah, so as I said, hyperacute T waves, they're going to be tall, a little bit broader than your hyperkalemic waves, okay? And they'll be symmetric, and they'll have chest pain. So that's it. I mean, if you look at all these other criteria which you match with the R wave and all, it's not something which you can, there are a lot of voltage criteria and all. I don't think that's a good take-home message. It's symmetric, it's tall, it's a little broader. Very narrow, pointed, tall is what you see in hyperkalemia. You can see a little bit normal patients who have a little bit tallish T waves, which I showed in that slide earlier. They would have a little bit asymmetric T wave. With the advent of TROPA, high sensitivity, is the diagnosis of unstable angina. It's very, very, very relevant. It's extremely relevant. Why? Because it's something which we see nearly daily in clinical practice. The patient actually comes with chest pain. So what is the definition of unstable angina? Like, it's not only the resting chest pain. A patient who has got recent onset severe effort angina. Okay, so patient has got recent onset severe effort angina. So he's saying, I was okay till 1 week. Suddenly, since 1 week, I'm not able to walk 10 steps. And then you look at the ECG and drop, it's all negative. So he's got a basically, the anatomy which we see in the cath lab is totally different. I have a hanging 99%, but I have some collaterals coming in from there. Therefore, it's not infarcting, it's not getting ischemia. Therefore, the troponin is still negative. But there is a critical amount of decrease in perfusion. So these troponins may or may not be positive, but you have to clinically understand that, the new onset effort angina, new onset rest angina, you got to evaluate. You don't do a troponin, you don't do a treadmill and all that. You have to, if you're clinically strong, you have to advise for early coronary angiogram. What are the differentials of AVR, ST elevation? Yeah, I mean, AVR, ST elevation, you can see sometimes with, in these kind of patients like LBBB and all that you can see, it is, you can see it sometimes in pericarditis. You can see it in the three-vessel disease pattern, which I said. And yeah, so those are the basic things. But then again, I always say ECG, people send you ECGs in WhatsApp and all that, but that's not to be entertained. You have to know the clinical scenario always. Why that is important. How to differentiate ST, T segment in posterior MI and D Ventr's pattern. Yes, it's very important. D Ventr's is you have that flat ST depression and T wave. So R, flat, top. The other one in D Ventr's just goes like this. That's how that goes. What are the easy findings for posterior MI? You go look at V2, V3, V4, you have an R, you have a positive T, and you have a flat ST depression. You have an R, a positive T, and a flat ST depression. So if you turn the page upside down, it will look like a Q ST elevation and T inversion of the posterior one. You can take V8, V9 in the back, and then look for ST elevation. Right, utility of CKMB. CKMB is also good. CKMB is very good for reinfarction. So in the curve of CKMB and troponin, troponin comes up from 3 to 6 and goes on for 7 to 10 days, right? CKMB comes down at around 4 to 5. So if you have a repain after say 1 week, you have pain at 1 week at 7 days, of an initial patient, if you want to look for reinfarction or re-ischemia, CKMB is very good because troponin, the baseline troponin will still be up. What is the time gap between chest pain and troponin? 1 hour. So you have the ESC guidelines who ask you for high sensitive troponin. You have to start looking at 1 hour, 3 hour, and then thereafter. Or many of us look at 6 hours and 3 hours because of our different troponins which we have. But the ESC guideline says to have a baseline because wherever finance is not an issue, you have a baseline at 1, 3, and 6. You can go on that. That's how the European Society guideline says. Difference between RBB and BB, I think that's a topic for another ECG masterclass, which I'll be hosting next month. I'm inviting you for that too. How relevant is loading dose in acute coronary syndrome? It is the only relevant thing in acute coronary syndrome. We got to start, it's like asking how relevant is treating acute coronary syndrome. Do you need to treat? Yes, we need to treat because it's very important because we want our patients to live. Yes. Okay, what kind of TV inversion is significant, flat, upsloping or downsloping? It's more significant in treadmill testing, which I'm going to get into the next talk. New onset LBV straight to cath or treat at NSC. If you are dead sure that it's a new onset LBVB, it's not coming up very much in the new guidelines. If you're dead sure that, last month's ECG is normal, you have crushing chest pain, now you have LBVB, yes. Today we have the advantage of looking at echocardiogram and enzymes. So I may not rush to cath, but if it is a very severe chest pain, yes, I would do that. It's not a very common thing. Comparison of troponin qualitative versus quantitative, it all again depends on the lab and we seriously I don't know. These qualitative tests, I'm not a big fan of that, but then it all depends on what is available at this thing. So I'll take the last question here. If tropa is negative in chest pain, how to approach? If it is negative, you look at your clinical scenarios. If you have a strong index of clinical suspicion that the patient is having a coronary chest pain, you have to observe the patient, take serial ECGs, take serial troponins, try to order an echocardiogram, and if you still think that all of these are negative, the patient has got significant, you have to refer for an early coronary angiogram because every person's life is important. We always hear these stories, a patient went to a casualty, checked, ECG was negative, troponin was negative, we gave pantosol, the patient died the next day. We cannot allow that in 2023. We cannot allow that in 2023. You have to have your clinical index of suspicion. If it's really strong, you have to have your index of clinical suspicion very, very high. So I think I'll wrap up and we'll wrap up with you. Thank you very much. We'll invite you all for tea and snacks.
Thank you very much, dear sir. I'm sure everybody has enjoyed and absorbed all you have talked here. Now we'll have a short tea break.
Yeah, we'll have a quick tea break for around 10 to 15 minutes and we'll wrap up. Thank you very much. Tea is on my left, on your right. Our people will be there to help you. I invite Dr. Hamza sir to lead us. works in KMCT Medical College, the head of department there in interventional cardiology. And he's a brilliant academician, interventional cardiologist, singer. What are the other talents which I should mention? Yeah, that's enough. Over to you, Sandeep.
Thank you, Dr. Salman, and welcome to this fantastic academic session. So the responsibility that has been put to me is to discuss about chest pain and the plausible different diagnostic diversities. I will not only be discussing about the non-ischemic part of chest pain, but there would be some interesting parts of chest pain that is related to ischemia too. So we will probably discuss in a case-based scenario so that these are mostly real-world case scenarios and how the different practitioners tackled it, how we tackled it, and how it went forward with various types of patient outcomes because of the various way it was tackled through. Mainly, why do we want to have all this discussion about chest pain and how the protocol should be followed? It is very important that we need to get to a diagnosis quick, because if the diagnosis is not properly reached up to, it can lead to complications. If the diagnosis is not properly reached, when we overtreat the patient, that can lead to complications, and all of this can lead to death. This can lead to bystander aggression, manhandling, which is often a fashion now, and medico-legal litigations. So we have to always weigh the risk of cost of evaluation versus the personal risk involved, personal risk to the patient, personal risk to the doctor as well. So how to approach this has been discussed previously. It is very important to go to the basics, the ABC, the hemodynamics, ask the right and relevant questions, the history, whether the pain is typical or not, the presentation of the patient, any past risk factors, past treatment, past history of any procedures, and the treatment that the patient is undergoing right now. So whenever we have a call from a friend, from a GP or a colleague, often, as Dr. Salman put it, we just get the ECG and nothing else. So what we need is actually history of the patient, not just the ECG. We might need a previous ECG too. We might need the presentation, what is the patient's current condition, etc. So it is very important that history and physical examination is put along with the ECG. Currently, ECG is not an investigation for us. It is part of the clinical examination. It's just an investigation by its name. ECG should be done for all patients with any suspicion of any chest, abdominal, or head and neck syndrome or pain. Then there are the routine investigations that we have discussed, troponins, usual investigations like the D-dimer. If you have the luxury of bedside screening echo, it would be good to send for a bedside screening echo. Chest X-ray, CT, I will discuss how a chest X-ray and CT are sometimes important in chest pain. And this is a protocol that should be followed for all patients with chest pain. The typicality should be assessed, the history, the examination. At least 2 ECGs should be taken. Never rely on one single ECG if you have any suspicion. You should go for another ECG as well. Preferably repeat between 4 to 6 hours. And at least 1 tropi should be done for all patients. We still have quantitative tropi now, but we still have qualitative tropi in the periphery as well. I think all of the qualitative tropi should be eradicated and replaced with quantitative tropi. If you have the luxury of HS tropi, that is also good. But there is a problem with HS tropi because it can be slightly elevated in many clinical syndromes, which may not actually mean acute coronary syndrome. It can be elevated in sepsis, any other acute pathologies involving lung as well. So always interpret the HS tropi very carefully. But what is more important is the the rise of this cardiac biomarker, and you should always repeat it, HS tropi or a tropi, at least between 2 to 6 hours apart. Sometimes we get the question from the GPs or from the ED that, sir, the patient just arrived, it is not yet time for the tropi to be repeated, we need to do it at 6 hours. That is not at all required. When a patient comes, we never know the initial window period. Especially for a diabetic patient, a silent event can happen anytime. So when the patient comes, always do a tropi at admission, and then you can repeat the tropi after 2 to 4 hours as per the protocol. So always follow the protocol, and then you won't be missing or making the patient go into any complication. If you have the luxury of a screening echo, it is extremely useful. If you have an echo in your clinic or an ultrasound machine, or you have an echo in the ED, always it would be good for looking the heart function, any RWMA, pericardial effusion can be picked up, etc. But better not to give a report to the patient, because ideally it should be countersigned legally by a consultant cardiologist. And when you have a doubt, and even if you don't have a doubt, it is always good to send the patient for a cardio consult the next working day. So we'll come across a few case scenarios. We had discussed this previously. It's slightly an overlap with Dr. Salman's talk as well, but the scenarios I would like, if you are writing up anything, just write up the final diagnosis so that you won't be too confused with the too much information that is passed on in the next few slides. So this is a 23-year-old female with chest pain. Are you thinking of something? Are you thinking of acute coronary syndrome? Are you worried? Again, you should follow the protocol for sure, but always remember that in young females and young teenagers with chest pain, these T inversions in V1, V2, V3 may actually be normal. It is called a benign variant or a persistent juvenile pattern, and you don't have to be worried about this, especially if there is no dynamicity. Always try to repeat a ECG if the chest pain persists. You should respect the chest pain, but if the ECG is just persisting like that, there's nothing to worry. A similar young male with 28-year-old with severe chest pain, similar type of chest pain, tropi negative from the periphery. It was the patient was given Rantoc and Tramadol. The symptoms decreased. Patient is happy. Doctor is happy. ECG. ECG is normal. What should you do next? This is actually a scenario that happened 2 years ago, and it is very commonly being still practiced. That is why Dr. Salman keeps on stressing the requirement of keeping the patient with you for a few hours, repeating ECG. Do not be happy about the patient's symptom relief, especially when it is chest pain that is concerned. So outcome, the patient went home after 3 hours, had a sudden cardiac arrest and brought to the same ED with VF, could not resuscitate. It would probably be an anterior wall MI. What we should understand is that 5% of patients with MI can have a normal ECG. It depends on which part of the evolution of MI this patient came to the ED with. So wait for a few hours and follow the protocol. Never give too much reassurance to the patient and the bystanders. Do a mandatory troponin test serially. Most common cause of death in MI is ventricular fibrillation. A middle-aged man with atypical chest pain, again you see prominent T inversions. What is more important is the tall R waves that you can see in the lateral leads, V3 to V6. So definitely you cannot rule out acute coronary syndrome if the patient complains of chest pain. You have to follow the protocol. But this is a classical ECG where we suddenly we cannot prove it without doing an echo, but this is a classical ECG of a hypertrophic cardiomyopathy. Many patients can come with chest pain and troponin negativity with this ECG, and it is mostly an apical hypertrophic cardiomyopathy. This is also a variant of ST changes. So this is a 56-year-old female. She has all the relevant risk factors: diabetes, hypertension, dyslipidemia, previous acute coronary syndrome. We don't know what type of acute coronary syndrome. She was already on antiplatelets for that. She came with chest pain and breathlessness, 4 hours. What is the ECG diagnosis? It is definitely an ST elevation in V1 to V6, actually QS in V1 to V3. So there is no problem in the clinical diagnosis that it is an anterior wall MI. However, there is a problem with the treatment. In the current era, in 2023, it is not appropriate to give a thrombolytic agent without confirming the diagnosis, because all ST elevations, all QS is not an anterior wall, just an anterior wall and a LAD occlusion. We have to think of other possible diagnoses. This patient presented with a massive GI bleed and heart failure, and patient was very sick on arrival, was on ventilator, HB was 8 gram%. We did a bedside echo, and this is a classic echo picture of one particular diagnosis. This is called Takotsubo cardiomyopathy or stress cardiomyopathy. After hearing the name, you will think it is a very exotic diagnosis. It is not. It is very commonly seen. We see stress cardiomyopathy every week, and it has to be diagnosed with a echocardiogram, and we need to prove it with a coronary angiogram, which shows only minimal lesions. So this patient did not require thrombolysis. We managed medically, and the patient improved. Takotsubo can present in various forms: inferior wall, anterior wall, NSTEMI, VT, VF. Any form of presentation can be possible in stress cardiomyopathy, and we have to be aware of this diagnosis. It is commonly seen in sepsis, trauma, cancer patients, etc. And sometimes it can overlap with MI as well. So this is a case of stress cardiomyopathy masquerading as MI. So this is another patient with severe chest pain. Patient did not give any proper history, came alone to the casualty with severe chest pain. Can you make a diagnosis based on the ECG? So we'll fit all this pattern into the LBVB-like pattern, or maybe this is mostly LBVB-like pattern, or probably the RBVB-like pattern, but this is actually a paced rhythm. You can see small spikes. The patient never gave a history, wearing multiple shirts, and the physician also forgot to examine this. Anyway, he referred the patient for acute coronary syndrome, but this patient has pacemaker spikes, and many a times the machine itself notes these spikes, and the machine reports that there is a spike in, it's a pacemaker rhythm. So you have to identify such patients. It is very important. Again, you have to examine the patient's chest wall. You might miss diagnosis like a previous pacemaker which was implanted 20 years ago, and also you might also miss some chest wall conditions like herpes zoster. 2 days ago in our OP, a patient came referred from the periphery with chest pain, opened up the shirt, saw multiple red lesions. It was a herpes zoster. So these kind of patients still do come to our OP. So it's important to examine the patient. You will never miss a pacemaker in the chest wall once you examine. Okay, this is a 54-year-old male, again with all risk factors: diabetes, hypertension, on Ayurveda. He hates allopathic doctors like us, and he came in an acute scenario with severe chest pain to the casualty. I was driving, and the ED physician told me, "Sir, it is a massive ST elevation. We can see ST elevation all over V2, V3, V4, V5, V6. I said, "Okay, what next? We'll plan for a primary." Then said, "ECG ST elevation also in 2-3 AVF. Okay, maybe a mid-LED occlusion, maybe a wraparound LED." Patient was not willing for primary, so shifted to the ICU. We had to give some sort of treatment. Patient was crying with chest pain. Then I asked them to do a screening echo. This is where many a times screening echo is very important. And we might be busy when we get the call from the ED physician or the duty RMO. And then I stopped the car, examined the ECG once more, and noted some things in peculiarly as findings. Can you tell me any peculiar finding in the ECG? Yeah, I think someone has talking about PR depression. I think so. So there's a PR depression in lead 2, and there's a global ST elevation. So when I told him, wait, don't thrombolyze, don't give heparin, don't do anything, let the reports give fentanyl and tramadol. And serum creatinine came as 7.8. The patient was a case of uremic pericarditis. It is very common, and some patients have severe pain, especially if they have mild pericardial effusion. And definitely no heparin, no SK. If you give SK in this scenario, patient can have an intrapericardial bleed. Can you make an ECG diagnosis? Yeah, so this is an early repolarization syndrome, very commonly seen in our scenario. So what Dr. Salman sir told earlier, you should look for reciprocal changes. If you see reciprocal changes, 99.9% it is ischemia. There are no reciprocal changes in this patient. This is an early repolarization syndrome. It can be seen in V1 to V4, also in 2-3 in the inferior wall leads as well. There are some high risk patterns of ERS, like inferior wall ERS can cause tachyarrhythmias in patients later on. So it's always better to ask them to visit a cardiologist for an advice, but this is definitely not an acute coronary syndrome, and ERS is very, very common. Okay, now this is a 60-year-old with diabetes, hypertension, again risk factors, severe central chest pain and back pain. BP was 200/100, no crepitations. ECG It's a direct diagnosis. You can see ST elevation 2-3 AVF, reciprocal changes 1 AVL, definitely inferior wall MI. So this is from a peripheral setup. Patient cannot reach the cath lab. So the physician calls us and asks what to do. I think you have to thrombolysis it to many a times aortic dissection. You can see the true lumen and false lumen in this particular contrast CT, and this is the dissection flap. Many a times a proximal aortic dissection, a type A aortic dissection can extend backwards and occlude the right coronary artery, and this can cause an inferior wall MI. It is an uncommon scenario, but this should be thought of. And obviously, if you thrombolize a patient with aortic dissection, it is going to be catastrophic. This patient needs aortic repair. You should examine the patient's both hands, as discussed previously, just not this, the dorsalis pedis, always examine both radial arteries together as well, so that you can pick up several other rarer diagnoses like all these atherosclerosis, Takayasus, and many a times a patient post multiple angiograms of the upper limb can have this radial delay also. That should also be kept in mind. Always do not think of aortic dissection when patients post angiogram. But it's always, aortic dissection, always keep a high index of suspicion. You can never diagnose aortic dissection without a high index of suspicion, especially when the BP is sky high and there are no crepitations, and when the patient complains of a tearing back pain. Okay, this is an 86-year-old chest pain, 1 hour loading given. ECG initially was normal, then this patient came with this ECG, slightly not clear. We can see ST depressions in lateral leads, 1 AVL to even 2-3 AVF, diffuse ST depressions. This is the scenario that Dr. Salman was talking about earlier. Unstable angina, tropi negative. The patient was not willing for an angiogram. When you see a patient with this LMCA-like pattern or a TVD-like pattern, definitely advise a coronary angiogram for that patient, regardless of the age, if the patient is healthy, because the angiogram is going to be life-saving, or it is at least going to document what the patient is having. Anyway, the patient was not willing for anything. On the day 4 of treatment, patient had VT, heart failure, ventilator. So that time the bystanders got the realization that they should undergo some sort of investigation, and this was the angiogram that was taken, and you can see that the left main coronary artery is 99% occluded. If it is 100%, there is no hope for the patient. Regardless of his age, this patient is going to die. And so we had to do an emergency angioplasty. Now you can see that the left main coronary artery is very well and wide open, and this patient is still following up since the last 3 to 4 years. So unstable angina does not mean low risk ACS. Tropi negative does not mean low risk ACS. It only means the myocardial damage has not settled in yet. So we need to follow up, we need to investigate, and we need to identify the high risk ECGs. 56-year-old, diabetes, hypertension, breathlessness since 3 days, cardiogenic shock, pulmonary edema. So you can see that this is an evolved inferior wall MI. We were treating medically again because the patient did not have pain, but the BP persistently 80, 70, 80, not at all picking up. Patient is in shock, patient is bad. But echo shows a good action should also be thought of, even if the patient comes in a stable, with a stable ECG, like evolved inferior wall, evolved anterior wall. You should think of mechanical complications. And this is very important to document, because you have to explain to the bystanders 95% of these patients do not survive. Free wall ruptures do not survive. But if the patient gets time, this can be repaired with a bypass surgery and a ventricular substitute repair. Sometimes, rarely, if the patient survive on to 2 to 3 weeks, we can often close it interventionally also by putting a device. Just like Madam showed, we put an ASD device for an ASD. We can put a VSD device for this ventricular septal ruptures as well. Again, to show another complication of STEMI, this patient was a patient with evolved anterior wall MI. You can see QS in V1, V2, V3, V4. Patient is very stable, only atypical chest pain. Patient not willing for primary angioplasty, is hence heparinized. However, after admission to the CCU, patient had a sudden cardiac P wave and QRS discordance and AV discordance. and that is a strong sign of complete heart block. You should always think of electrical complications of myocardial infarction. CHB with anterior wall MI is very dangerous, and patients have to be put on temporary pacemaker and have to get a revascularization or they will die. So you have to think of the electrical complications of MI. Another scenario, a young female postpartum day 14, sudden chest pain, diffuse T inversions, just like the T inversions that I showed earlier. I don't have the ECG. Tropi, so it was HS tropi, it was 2.4, which is positive, 0.4 is the cutoff. Patient had RWMA, good LV. All the other routine reports are normal. It is diagnosed as an NSTEMI. So a 26-year and patient is put on heparin from a peripheral center. 26-year-old with no relevant risk factors, NSTEMI, it is very unlikely. So then that is when we should think of diagnosis like non-acute coronary syndrome, troponin positivity, any myocardial injury without a vessel occlusion. This could be myocarditis. So myocarditis is a very important diagnosis you should make. It is very common scenario in the COVID era. And we still see lots of viral myocarditis right now. These patients do not require heparin. When you give heparin, this patient, if there is a myopericarditis, actually the effusion can increase. So we have to do an echo. And if there is a suspicion, do not hesitate to go for a coronary angiogram, however young they are. So myocarditis masquerading as MI. And this is a 47-year-old lady with atypical chest pain, no exertional symptoms, no risk factors. Can you make an ECG diagnosis with this? These are mostly mimics of the various ST changes that we are discussing. STEMI again. So again, this is a Brugada pattern. You should always think of the Brugada. It is very common actually, the Brugada pattern, and the Brugada syndrome, where the patient can actually have a VT, VF and die. I'm not going to the details of the types of Brugada pattern, it will be confusing for you, but when you see an RS, R dash with an upcoving ST elevation like this, think of the Brugada pattern. And it is always better to ask them to get a cardio consultation, definitely, because there are some implications. We have to get a proper family history, whether there's a history of sudden cardiac death, because we do have patients, even physicians among us who have had a VT, VF due to the Brugada syndrome and survived and not survived. This is a 21-year-old postpartum lady again severe chest pain, 4 hours. ECG, you can see there is T inversions, something like a Wellens pattern of V1 to V3 to V4. Whether it is an anterior wall MI, there is also some Q waves in 2-3 AVF, so probably middle AD occlusion. Again, instead of directly going for a thrombolysis, we have angiogram cath labs available all over the town right now. Take up for primary PCI, do not give medical treatment for such patients. This is, even though this is rare, we have to identify such patient. It is a spontaneous coronary artery dissection of the LAD. It is not even though it can be labeled as an acute coronary syndrome, it is not due to a coronary artery disease, atherosclerotic as such. So these patients should be, it is in the postpartum, the SCAD can happen. When we have a postpartum lady with sudden chest pain and ECG changes, ask them to get a coronary angiogram, and this can be diagnosed. And these patients should never have a thrombolysis. This can extend the dissection and cause catastrophic complications. And this is another scenario. This is also a very common scenario which you might have faced several times. 82 years old, sudden chest pain, dyspnea, tropi positive. Patient was diagnosed as evolved anterior wall MI. We can't blame them. There is QS, there is ST elevation. But what is more prominent is the tall R waves that should have been noted. This is an LVH with strain pattern seen with many cardiac conditions. And however, the patient was given thrombolysis again from outside. 82-year-old never thrombolized without making a proper diagnosis. Always send for detailed evaluation before giving thrombolysis. Patient again had a severe GI bleed naturally, collapsed, and the echo done on the next day after referring to us showed severe calcific AS, and this patient was having severe calcific aortic stenosis with Hayday syndrome. You know what Hayday syndrome is? It is angiodysplasia of the colon due to severe AS. So what will happen if we thrombolize a patient with angiodysplasia? And that is what happened to this patient. So LVH with strain pattern. can have secondary ischemia, and that can masquerade as anterior wall MI and be mistreated. And always auscultate these patients. If you auscultate these patients, you will never miss the ejection systolic murmur, which is going to be very loud, rough, and radiating. And when we hear such a murmur in a patient with MI, think of VSR. Then, like I showed before, think of aortic stenosis as a bystander, think of mitral regurgitation, which can be as a bystander diagnosis, or it can be a mitral regurgitation due to the MI itself. Okay, again a 28-year-old lean man with acute right side chest pain one day, severe chest pain. This patient came to us, ECG normal. We cardiologists very rarely tend to do chest X-rays for such patients. However, this patient went back to the physician. The physician took a chest X-ray and referred back to us this is a common scenario, and I have had a few scenarios myself. It's a very interesting X-ray. I hope you have a diagnosis for this. Very difficult to pick. I had to look from multiple angles in this X-ray itself. This X-ray was provided to me by Dr. Salman, but I have had similar experience in my OP as well. It's a very subtle pneumothorax in the right upper zone area. These pneumothorax are very often missed. Even if we do the X-ray, we have to be very careful in picking up such. If you have a confusion, always ask the help of our pulmonology or physician colleagues. Okay, so this would be my last patient. So anyone can be fooled is the topic, because a whole department was fooled. This happened during my DM days, so it is a very old. I think a few of you might have already seen the slides. This is a 12-year-old case. Patient is now 40 years or so. 27-year-old male who was a manual laborer, sudden severe retrosternal chest pain. Provisionally diagnosed from the city as acute coronary syndrome. Okay, the troponin was positive and there are ECG changes. Patient went to multiple tertiary level hospital, then patient had no finances for any angiogram, referred to the government sector. The patient had clinically tachypnea, tachycardia, hypotension, hypoxia, and you know the difficulties with the initial management in the government sector. All the basic tests are being done and reassured, but we finally never get to see them properly. Anyway, patient had fine inspiratory basal Krebs. TROP-I was positive, and the D-dimer was high. So instead of the acute coronary syndrome diagnosis made from the outside, we made a diagnosis of probable pulmonary embolism. So, and this was actually, we directly went ahead with the echo, and we can see a severe tricuspid regurgitation, if you can note, and there was severe PAH. So at that time, we could not get a time for a CT, but the cath lab was open. So we can, when a patient is suspected with pulmonary embolism, you can always do a cath lab imaging too, if you have the cath lab open. And nowadays, in the West, instead of patients being treated with thrombolysis, the primary management of acute pulmonary embolism with hemodynamic compromises, catheterization and probably aspirating the thrombus from the pulmonary artery, and catheter-directed thrombolysis. Only if that is not possible, people do a systemic lysis. So that is one upcoming change in management of pulmonary embolism. So that is why we took up for a pulmonary angiogram. However, we were surprised to see that the pulmonary angiogram, this is the IVC on the left side, and the pulmonary angiogram of the left side and the right side was absolutely normal. There was no thrombus at all. Now we have a confusion. So what is the actual diagnosis? Then we thought we'll repeat a chest X-ray. So a digital X-ray was taken, and this time we could see many significant findings. Actually, the initial X-ray was very vague and not at all properly taken, and I think nobody looked at it at all. So this was, we can see multiple findings in bilateral lungs and reticulonodular shadows, and one very interesting sign. This case was published for this sign, and this is called a continuous diaphragm sign. If you note, there is a gap between the cardiac border and the diaphragm. There is a black line between the cardiac border and the diaphragm, which is not normally seen. And this is a classical picture of pneumomediastinum. So this patient had a pneumomediastinum, diffuse ground glassing opacities was found in bilateral lung fields, and the final diagnosis was actually hypersensitivity pneumonitis, which was a radiological diagnosis. We took a history properly again. He was caretaking the employer's PGN since the last 1 to 2 months. This was a diagnosis of Bird fanciers lung with hypersensitivity pneumonitis, and the patient was put on steroids, oxygen, everything was fine. Patient improved, pH improved. So what is the learning point is that even though in an acute, this is called an acute corpus mill, acute RV failure or acute myocardial injury because of an acute lung event. The most common cause of an acute corpus mill is pulmonary embolism, but again there are still rarer causes that can happen, but still pulmonary embolism should be ruled out in all these cases. And again, this was an error because a proper chest X-ray was not properly interpreted in the beginning, and it should have been there. So again, this is all the differentials that we have gone through: acute coronary syndrome, myocarditis, pulmonary embolism, atrial dissection. You should also think of less riskier diagnosis: muscle spasm, costochondritis. Cervical angina is a common symptom for patients with a significant cervical IVDP. Then again, colic, pancreatitis, all can present with chest pain, and you should also think of that. The rarer differentials of STT changes, we discussed sepsis can have lots of STT changes, electrolyte imbalance, the Brugada pattern, IC bleed can have deep T inversions, but the clinical scenario almost points out towards an IC event. Hypothermia can cause something called as the Osborne waves, which are also ST elevations, the J-point elevations because of the hypothermia. Trauma can cause myocardial injury and cause ST elevations. Long-standing ventricular aneurysms, never forget a patient with old anterior wall MI, patient coming with chest pain again, you don't have to thrombolyze again. This could already be a patient with previous ventricular aneurysm. So you should always refer to a cardio for an echo. Again, pulmonary embolism can have ST elevations. Thank you.
Thank you very much, Dr. Sandeep, for that very exhaustive and fantastic outline of so many clinical scenarios which we are likely to see in day-to-day clinical practice. For those who have joined in late and are not familiar with our setup, please open your internet browsers, go to menti.com and type in the code 86287544 for our clinical interaction. The floor is open for clinical discussion to Dr. Sandeep. Right. So those who would like to get in can please do so. We can ask questions. Right. So I'll set the ball rolling, Dr. Sandeep. I think one of the main important points which you mentioned early on was early repolarization. Could you just again touch up for those people who don't understand what exactly does this mean? What is early repolarization? Is it normal? Is it benign? Is it going to be there throughout for him? For those who are not familiar with it.
Early repolarization. See, repolarization is the electrical part of the ECG cycle where the heart is, the relaxation corresponds to it. So all the repolarization changes comes in the ST segment. So in some patients, there is an early repolarization like feature that is happening, and these patients have an ST elevation like pattern. This is actually an electrical pattern seen for a few patients, but the problem with ERS is that in some leads, since the early repolarization pattern, like the inferior leads, there is a higher risk for ventricular arrhythmia. These patients do not have any risk for acute coronary syndrome as such, but since it's an electrical abnormality, there is a chance that there could be a ventricular tachycardia or ventricular fibrillation very rarely. So these patients should be identified. Mostly it is seen in the anterior leads V1 to V4, but it can also be seen in the inferior leads 2-3 AVF, and 2-3 AVF early repolarization syndromes should be referred to the cardiologist for further advice.
Okay, we've got some questions coming up on the screen. Is age a bar for an angiogram?
No, age is not a bar. We just had an example yesterday. We did an angiogram of an 86-year-old person yesterday. He was absolutely healthy, but the situation was that this patient came with chest pain, advised admission from outside. Patient was absolutely stable, but we needed to know what is going on inside the heart. If you have a patient who is stable, who is healthy, who is active, who has another 2 to 3 years in his expected life expectancy, you can always go for an angio as long as you're confident with the backup. Angiogram is not completely risk-free. You have to be aware that you have to be very judicial when we use it, but age is not a bar as far as the upper age is concerned. We have also done angioplasties for 90-year-olds,
Yeah, exactly. I mean,
97-year-olds.
meaning if a 90-year-old comes with an acute inferior ST elevation MI with bradycardia, you can't just look at him and say you're too old for anything. We just have to intervene. And we're very surprised once in a while. It's like a very straightforward lesion for us to tackle, and God determines his lifespan, not us. Right? Great. How does a physician diagnose a mechanical complication like septal rupture?
So the only thing you can use is your stethoscope, and if you can identify a systolic murmur, this can again be an aortic stenosis, but you have to keep your index of suspicion high. Patient with MI, patient with cardiogenic shock, heart failure, and a systolic murmur, think of complications like septal rupture, but you need to make a final diagnosis. You definitely require an echocardiogram.
Very important point which he mentioned, which we teach all our residents here. Any MI, once we see the ST elevation, we get carried away. The ST elevation run. But then auscultating, very often, sometimes we even can probably miss in the echo, but this harsh murmur of the ventricular septal rupture is something which is very, very, very important. How do we confirm pericarditis, Dr. Sandeep?
Pericarditis, if you don't, first of all, rule out myocarditis associated. Tropi should be negative. We cannot confirm pericarditis. It is a clinical diagnosis. A mild pericardial effusion associated with chest pain, and typical symptoms can lead to a clinical diagnosis of pericarditis. There is no particular blood test or investigation to diagnose pericarditis.
So how many hours should we repeat a troponin?
So we just discussed that. Maybe repeat every 2 to 6 hours, maybe at least 2 troponins for a patient, at least. So a single troponin often do not give a confirmatory diagnosis. The serial rise of troponin is what is important. Between 2 to 6 hours would be appropriate. If you have HS tropi in your institution, even 2 hours would be good for an early diagnosis. If you don't have HS tropi, maybe towards 4 to 6 hours.
So in pulmonary embolism, is there a preferred lytic agent for those who have hemodynamic instability, those coming with shock?
No, the usual lytic agents, streptokinase, tenecteplase, and alteplase can be used for. Each of them have a different dose pattern, and when we are giving catheter-directed thrombolysis, the dosage is different. If you are giving systemic thrombolysis, just like in peripheral thrombolysis that Dr. Bijoy just discussed, it is the same system of thrombolytic dose.
In that patient with small pneumothorax, we saw a small leftward axis. Do we have any specific ECG changes for pneumothorax?
No, usually not, but the axis can always, see in that particular patient there is no, that left anterior hemiblock is not at all relevant because it was a small pneumothorax. But if you have a large tension pneumothorax, definitely the axis can change depending on which side the pneumothorax.
Exactly, right. So any rare complications which can occur after an angiogram?
Yeah, one is the loss of the pulse can happen in few patients. We have had rare AV fistulas which needed to be tied up post angiogram, and very rarely, depending on the anatomy of the patient, we never know what is going on inside the aorta. The patients can have systemic embolism. Very rarely strokes can happen, peripheral embolism can happen. It is very difficult to pick up these patients previously, but we have to, that is why the indication should be strong before doing an angiogram. It should be documented very strongly. No procedure is without risks.
Okay, for the want of time, we have a lot of questions coming in, but I'll choose a few questions. Young MI is increasing. What are the reasons in your experience? We can give a long talk on that probably.
Yeah, I don't think it's...
Yeah, but yeah, so the usual risk factors.
Usual risk factors, genetics.
BD.
In India, genetic studies are ongoing. We have, in our scenario, 15 to 20 years, we are younger for acute coronary syndrome compared to the West.
So a person with a positive treadmill test who is fearing to do an angiogram, what is the best advice we can give? How do we manage such a case?
Positive, fearing
So
an
I think we'll hold that question. It'll be coming up in my talk. Okay, right. How much rise of tropi is significant?
So there is a serial increasing trend of tropi is significant. Again, I told you the fallacy of HS tropi, never rely on a 35, 45, 55 nanogram per ml of HS tropi. This can happen in many systemic conditions. A serial definite increase in rise, maybe 2 to 3 times, is more important than a borderline HS tropi.
So we have an interesting question. Can a PCI cause an MI?
So,
very creative question.
So that's a iatrogenic complications can happen for any procedure in medicine. So PCI, if the anatomy is difficult and during catheterization and catheter handling, if we inadvertently close off the vessel nearby, it can cause a myocardial infarction. So yes, PCI can also cause MI. It should be very carefully done.
So we'll go for the last question, TROP-I versus TROP-T in any
TROP-I is more commonly used in our setup, and it is more available. You can use either of them for a diagnosis of myocardial infarction. Some say that TROP-T is more non-specific in as far as renal failure patients are concerned, but you can use either of them, whatever is available in your setup.
If you want, you can answer this controversial question. How do we convince patients and bystanders who refuse CHXA based on a senior cardiologist's viral video who strongly...
I think I should not comment on that in this podium.
Yeah,
that
okay,
itself might get viral.
Yeah, that's right. Okay, so comments. So thank you very much, Dr. Sandeep, for that excellent talk.
Thank you.
Outlining various clinical scenarios. Very well taken. Thank you.
There was a talk on the differential diagnosis of ACS, mimics of STEMI and evaluation. Thank you very much, dear sir. Now, I would like to call upon to the stage Dr. Praveen Srikumar, Senior Consultant, Interventional Cardiologist and Electrophysiologist, to give his talk. Welcome, sir.
I'll introduce Dr. Praveen. He's very senior interventional cardiologist and electrophysiologist, primarily based in Aster Med City, but we have the honor of having with us as a weekly visiting cardiologist, a strong academician, a brilliant interventionalist, a brilliant electrophysiologist. He's going to talk to us on tachycardias and arrhythmias and what we are likely to see and how we can approach. Over to you, Praveen.
Thanks. Superfluous in the introduction, but anyway, I'm junior to Salman. He's much senior to me. The thing is, I'll just go on with some cases. First thing, I just wanted to follow up with some discussion which was going on regarding early repolarization. Early repolarization, it was mentioned, Sandeep, as he has truly mentioned, inferior early repolarizations are more dangerous. There is something called as a benign versus malignant. Nowadays, the Brugada group was interested in this aspect, and they had the original workers, the Brugada brothers, Pedro, Simon, and Joseph Brugada. So they had followed up many families, and they found that there were many young people in those families who had repolarizations, and some of them turned out to be Brugada later in life. So that is something interesting. They have a series still. This was an original thing which was told to me by one person who had done fellowship with Brugada. So they told that they are still following it up, not yet published because they are not sure of what is happening. Still the disease is still being investigated. It was found in 1992. Still many things are going on, and they say they also hypothesize that early repolarizations, at least some of them, are actually a continuum of Brugada later in life. So that is something new which is coming up. And so actually today there is one patient in CICU in Kochi, a young guy, 28-year-old, recurrent syncope, 22-year-old, recurrent syncope, ERPS like pattern in inferior leads. We did a flecainide challenge test. It is easy to do. We admit them, give 9 tablets of flecainide, which is 50 milligram. So 450 milligram is given, and serial ECG is taken, or and maybe next day you can do a diagnostic EPS why the flecainide level is there in the body. This is one way of differentiating a benign versus malignant repolarization. So we can restratify, but this is the only way to restratify. Whether that transmit to a clinical risk, we don't know. Even Brugada group is not sure. Just a word to start off. Anyway, I'll just go with some cases. This is a 35-year-old male presented with recurrent episodes of palpitation. These are original cases that we had with a frequency of 1 episode every 3 months, no episodes of syncope. Basically a 35-year-old with palpitations. This probably everyone would know. Can somebody comment on with what is it? It's an LBBB or what? Is it sinus rhythm? First thing is whether it's a sinus rhythm. So there are P waves, so probably P waves. But what is notable, it's a very short PR and an LBBB like pattern. it's positive in V6, so looks like an LBBB pattern. So whenever there is a short PR, you need to suspect a pathway. So this is a pathway ECG, and this is pathway in sinusism. When it shows a delta wave, what it means is that the pathway is antigradally conducting, and it has potential to create trouble. So it can create a tachycardia. So that is the thing. So suppose in such a patient, suppose he is very asymptomatic Brugada, you can do a treadmill test to see whether the pathway is conducting at higher rates. So it's a non-invasive test. So this will become suddenly narrow as exercise goes on. It will become a normal ECG. If that is so, you don't need to do anything. That is how we can simply restratify a pathway. If they are symptomatic like this patient, then you need to do something. Then you usually intervene. We did ablate this pathway. This is a post-ablation pathway. You can see that it normalized. The PR interval has become normal. The delta wave has gone. The total axis has changed to a normal pattern. So basically, the PR interval has normalized. So this is a short PR. The pathway can be localized by the way you see the ECG. For example, here there is a small delta positive in V1. This delta positive in V1 usually indicates as a left-sided pathway. In ECG localization, whenever you want to differentiate between right and left, you look at one lead which is V1. So V1 differentiate between right and left. Upper and lower is differentiated by 2,3 AVF because 2,3 AVF is the inferior leads. So something you want to know whether it is upper or lower, the basic is that you look at 2,3 AVF. Suppose you want to know left and right, it is V1. Now, then it depends on. Then suppose it is left side, suppose you have something negative wave in lead 1 and AVL, you know that it is something which is originating in the left side, extreme left. So that will be very left. Maybe LV, basal LV, some electrical activity originating from there will be negative waves in left side. So suppose you have a positive wave, delta wave in lead 1 and AVL. Lead 1 and AVL. AVL is not very clear, but lead 1 is clear. So here it is, if it is left septal, it is septal, towards left septal. So it's left septal. Now whether it's anterior or posterior, suppose you have a positive in lead 1, because 2,3 AVF are inferior and posterior. So suppose here it is positive in lead 2 and 3, delta waves are positive here. So that means that it's our anterior. So you can directly localize the delta wave to be left posterior and anterior. So it's a left posterior and septal. So it's a left posterior septal pathway. So the basis is that suppose you are taking up this space, you know ahead that you need to do a transeptal puncture or go to the left atrium and ablate. So it's somewhere near the mitral annular Ken pathway. So not only in MI also you decide on, for PCI you decide based on ECG. So you have an ECG of MI, you know which catheter to be put, what to be put in a short period of time. Similar in EP also, you can localize it and so that you can manage it. This is second case. 25-year-old presented with multiple episodes of palpitation for 1 year. ECG during tachycardia shows narrow QRS, which is suggesting an orthodromic tachycardia. Baseline ECG shows again pre-excitation. So again we need to, here in contrast to what we told, V1 is negative. The delta is very clearly negative. So this is a right pathway and this is negative. 2,3 AVF are negative. So inferior leads are negative. So it's posterior or inferior. So towards the base of the heart. So it's a right posterior pathway. And again, lead 1 and AVL are positive, means again it is more septal. So, and with the transition of delta wave in the V1 to V2. So that also indicates that it's a septal. So this is a typical right posterior pathway. And this is a mimicker of inferior MI. You can see the QS into 2, 3 and AVF. So this may mimic an inferior MI, but actually if you see, it's the difference is the repolarization changes in these are like LVH. It's very predictable. It will be asymmetric, always the same constant pattern without any change. So that's how, if you have serial ECG, you can differentiate whether it's a pathway, LBBB, etc. from a coronary syndrome, because in coronary syndrome it's dynamic. Repolarization area is dynamic. So this will never be the same, it may change. So if it's always constant, then the other diagnoses are more common. This is a post-ablation of the same patient. You can see that the delta waves have all gone. It has narrowed, QRS has narrowed, and delta waves completely. This is the actual ECG of the person. Why WPW syndrome causes an altered activation is because it directly activates somewhere else in the ventricle. rather than the AV node. So that's how the repolarization changes. This is another 39-year-old female with lactating mother of 4 months old baby presented with palpitation, breathing difficulty. So she was reverted with 6 milligram of adenosine. This is the ECG. Here you can note that this is another, when we see a narrow QRS tachycardia, this could be either any supraventricular SVT is a common term. Even though the term SVT is used for pathway or a AVNRT, these are ideally AVNRT and pathway mediated tachycardia are called SVT in general terms, but actually the term is AV node dependent tachycardia. So SVT is a very broad term. It can include flutters, atrial tachycardia, anything above the junction is called as a supraventricular tachycardia. So there are two divisions, supraventricular or ventricular tachycardia. SVT is a broad term. Now, if it's an SVT, this is a regular, the next thing to see is it's a regular or irregular. So this is a regular tachycardia. If you note that they are exactly regular, if you want, you can use a caliper. Caliper is not a scale or anything. You can mark a paper to 2 marks or 3 marks, and that is a caliper. So if you caliperize it, you can note that this is a regular tachycardia. Next thing, when you have a narrow QRS regular tachycardia, next thing you see is the P waves. So here you can see a clearly P wave here. These are the P waves which are retrograde, which are very small. How to differentiate between a P and a QRS is that QRS is a very sharp spike. It just goes up and comes down. But P waves are very smooth. They have a ball nature. So that's how you identify a P wave. So here you can see that the P waves are regularly occurring just after the QRS and very shortly occurring. So this is an AVNRT, typical AVNRT, very short RP tachycardia. These are otherwise called by many names like pseudo S here and pseudo R here. So here you can see a pseudo R, which here it's not very clear. This is pseudo S. Suppose it's a pathway, sometimes you can localize the pathway. In a left-sided pathway, you can get a negative P in 2,3 AVF like this. But here it's an AVNRT. In the management, mainstay of most FCT is still drugs, medications. First thing you need to do is vagal management. When you see such a patient in casualty in tachycardia or in distress, distress including hypotension, then many vagal maneuvers help them mitigate the thing in an acute situation. Either you can do a Valsalva, ask the patient to cough with a closed mouth, violent cough. You can use cold water. You can use cold ice pack near the or just behind the ear. Jacobson's nerve is behind the ear, so they sense from the auditory canal and stimulate the vagus and stop the tachy. All SVTs use adenosine first. Why adenosine? Because adenosine has a very diagnostic value. The value is that it only acts on the AV node. So immediately you know that whether it's a AV node dependent or a non-dependent tachycardia. Even in a VT, you can use adenosine because it will bring out VA blocks. So without stopping the tachycardia. Even that is very diagnostic. In an AVNRT or AVRT, which are AV node, the classical SVTs, they stop. Tachycardia stops. In an atrial tachycardia, tachycardia continues, but ventricular rates become slow. So you can bring out P waves. While doing an EP study, this is exactly what we do. When the tachycardia, when we want to map an atrial arrhythmia, you give continuously give adenosine and map the P waves, so that R waves won't interfere with your mapping. AF continues, but when again ventricular rate becomes slow. So adenosine is very diagnostic. So for example, it can bring out P waves like this. This is a atrial tachycardia or flutter going on. So when you give adenosine, it will become, the P waves will be exposed. So even if you are in casualty, if you have adenosine, it's very useful. Only thing you need to connect the ECG and give adenosine. You connect the ECG, start on the ECG machine, and then give adenosine. That is equivalent to doing a diagnostic EP study, and it actually saves much time and effort for the patient. Next is this is a mechanism of re-entry. While in an AV node nodal tachycardia, it's the re-entries around the AV node. While here it is another pathway, so it's a bigger circuit. So otherwise there is no difference. Both involves AV node. The circuit involves AV node. So when you stop the AV node, you can stop the tachycardia in an acute setting. And this is another short RP tachycardia. This is an AV nodal re-entrant tachycardia where you can see the P waves. While P waves may be slightly away in a pathway, like in this case it's a pathway. Pathways are usually very fast, like here the rates are around 250, while here the rates are around 300. 300, the faster rates are with pathway than AVNRT. More ST depressions because of activation through ventricular muscle, altered activation through ventricular muscle. ST depressions and changes are more common in AVRT. These are very subtle changes, but still you can in a way differentiate AVNRT or AVRT by ECG at times. Now AV node independent tachycardias include atrial tachycardia like this. In atrial tachycardia, what you can see is that you may not see any P waves. Unless you give an adenosine, you may not see P waves. And this is a flutter. You can see the typical sawtooth pattern. Again, when you give adenosine, you will bring out this sawtooth base more clear if it's a 2:1 AV flutter, 2:1 flutter. So this is flutter, and fibrillation, of course, you know there won't be P waves or will be fibrillary P waves with irregular QRS. And this is a third case. This is again a lady with a tachycardia. This so again the same localizing principles apply to ventricles also. So like here you can see that you can localize the ectopics are coming from left side because it's a RBBB pattern. Suppose it's an RBB pattern, again you see at V1. So suppose the morphology is RBBB, then the origin of the ectopic is LV. So it's an LV. Now LV, it is somewhere mid LV because these are not tall. Suppose these are tall, this is typically from the outflow tract. If they are truly negative, they are from the apex. So this is from somewhere from the mid LV, and again lead 1 AVL, you can see that they are positive. So they are from septal. So they are from the septal area mid LV. So septal area mid LV, then you think of anatomy. What are structures there which can cause tachycardia from the muscle? One is posterior fascicular area. Second is a papillary muscle, medial papillary muscle. These are two areas which are notorious to produce VT because there is automatic tissue there. So the differential diagnosis in this case is a medial papillary muscle VT or a left posterior fascicular VT, which is very common, idiopathic fascicular VT. So these are couplets. When this comes like this in a young female with palpitation plus or minus syncope, then you need to act because there are two ectopic. These are called couplets, and couplets produce a group beating here, almost a group beating. So when there are couplets, they are of high significance. Bigeminy and trigeminy are like trigeminy is less significant than bigeminy because the frequency is less. So more problematic is couplet than a bigeminy or a trigeminy. So bigeminy is even more severe than a trigeminy, but if they produce couplets, then that is actually a pre-runner of VT. So suppose you see couplets, they are more prone for VT or a dangerous arrhythmia. Suppose you get exercise-induced VT. It's another area where you need to work up the patient very well. Suppose the patient has a exercise-induced arrhythmia, any exercise-induced palpitation, they are more of a riskier candidates. To one in elderly, the most common arrhythmia causing exercise-induced palpitation is, it's not exercise-induced VT, exercise-induced palpitation is atrial fibrillation. Second is RVOT VT because they are adrenergic related. Then long QT syndrome causing VT. In children, if the child says that while walking, or parents say that child while walking gets suddenly have syncope with palpitation, then the first thing to rule out is a long QT. That's the most common presentation of a typical type 1 long QT. Children who falls down or have palpitation, they say palpitation and then they fall down when they start playing. So that is one of the classic presentation of long QT syndrome VT. Another is a bidirectional VTs which can happen in CPVTs. That's also adrenergic related. So most common adrenergic related arrhythmia is actually atrial fibrillation. So when some person, elderly person or a middle-aged person, hypertensive, says that they have exercise-induced some palpitation, first thing to rule out is atrial fibrillation. This is another case, 13-year-old female presented with recurrent episodes of palpitation for 6 months with recurrent hospital visits for same, treated with propranolol. So this is arrhythmia. So again this shows a narrow QRS tachycardia. P waves not very clear in this case. The rate is almost exactly 150 to 150. So this could be an focal atrial tachycardia. And this is a post-ablation of that same patient which brings out the P waves. This is another case of recently diagnosed type 2 diabetes, presented with chest pain, palpitation 3 days, went to outside hospital, ECG showed a white QRS tachycardia, was converted to sinusism with a shock. Sometimes pathways like this can cause white QRS tachycardia when the pathway conduction reverses. That is, through the pathway it goes from atrium to ventricle directly and back to AV, through the AV node. So that can produce a white QRS tachycardia. Again, this was ablated post-ablation. I think it's the same. This is another pathway where you can localize that. Again, it's a positive in V1, which is a left side pathway, left anterior pathway because it is positive in 2,3 AVF. So it's a left anterior pathway, again post-ablated. This is a typical flutter. In flutters, you can note that whether it's a typical counterclockwise or clockwise flutter. So this is a fairly atypical flutter because it's not typically sawtooth backwards or sawtooth in 2-3 with negative in 2-3 AVF. Suppose that is so, it is typical flutter. This is an atypical flutter which is clockwise. Post cardioversion, this was the ECG, and after that connected a Holter and this showed this. So when you see flutters, you can have a tachy or a Brady syndrome in the same patient. So in such patients, what is decides management is the symptom of patient. Suppose they present with syncope, probably initially you may have to pace and later think of and give drugs. After pacemaker, give drugs, beta blockers in strong dose, and later if required, if they have symptomatic or pacemaker device diagnostic source recurrent tachycardia, then you can think of management of tachycardia aggressively. Again, this is again a pathway. This is an Ethiopian patient where this this shows this again a left side pathway. It's a septal pathway. It's a septal, very anteroseptal pathway, left anteroseptal pathway. And here such cases, even from ECG, we know that it's slightly risky to ablate because it's very near the AV node. So here this case was done with under cryoablation. Patient had a congenital RBBB. After ablation, that RBBB resurfaced. So this is a actual post-ablation ECG of patient showing congenital RBBB. This is another case. This is a ventricular bigeminy. When we localize this again, this is a predominantly negative one, QRS. So right-sided upper one. It's from outflow. So it's a right outflow tract VT because 2-3 AVS is positive. So it's from above to below. So this is a typical RVOT VT. And this is how we ablate. When we map it, you can localize the RVOT to somewhere on the anterior RVOT. So that was point focus ablation done at there. This arrhythmia is the most common arrhythmia. It's an AF, narrow QRS tachycardia, irregular. So once it's irregular tachycardia, that is atrial fibrillation. And for atrial fibrillation, there are many indications for SVT ablation. So SVT initially can be on drugs. But these days, the indications are more for curing it rather than keeping on drugs because success rates are very high, complication rates are very low, so they can be cured. Another indication when they cause tachycardiomyopathy. So if a progressive echo shows dilatation or heart failure, then whatever be the arrhythmia, when treated, patients walk out without any heart failure medications. And high risk occupation, people who work in heights, pilot training, precision work, all require management of arrhythmia more aggressively. In a diagnostic EP, multiple catheters are put in the atrium and ventricle, and we do pacing maneuvers. This is how an EGM looks like. An intracardiac EGM, for example, this is a fused EGM in a single line showing that it's an AV and RT. And post-ablation, this is what we have. It's a sinusism which is normal, A and V can be seen. And in a pathway, you can see that there are fusion. So, for example, here it can be known that it's a mid-septal pathway. This again is dangerous to ablate, but this case was ablated. This is a Cox triangle where AV and RT, the most common ablations are done. And pathways are ablated around the AV node and mitral annulus or tricuspid annulus, and multiple areas you can have pathways all over, and you can have it outside epicardium also. And multiple energy frequency, you commonly use radio frequency, although you can use cooling like cryoablation or laser ablation, so or pulse field. This is a focal atrial tachycardia, the same case which we had shown earlier. There is a focal atrial tachycardia which could be ablated from left atrium. This is a map of the left atrium. This is how we get. We make an electroanatomical map. So when we touch, the ECG produces the anatomical map. So you get an electroanatomical map, so that shows the focus in different colors, which we can assign it. So here red is the earliest point. So that's the earliest point locally of local EGM. So you can know that from there the mechanism of arrhythmia is a focal tachy. In a flutter, it looks like a circle, like different colors happen. For a VIBGYOR color, like here, so from the pattern of color, you know that this is from here to here. This is early, violet is late. It reverses like this. So this is a flutter. So flutters are macro re-entry. So you can see that, virtually see that in a mapping. And for atrial fibrillation, rate control and rhythm control are the mainstay, definitely. But there are people who need ablation because they go into pulmonary edema despite many drugs. And again, tachymyopathy with AF is an indication for ablation. For structural normal heart, we don't unfortunately have dofetilide, but that's a drug by textbook or preferred drug of choice. What we have is propafenone and flecainide. Propafenone has slightly less QT prolongation compared to flecainide. Flecainide also has QRS prolongation. That is one problem with flecainide. Propafenone, unfortunately, is less well available. Only one company makes it in India. MCure Pharma makes it, named as Pradil. Only one company is there. But if it is available, probably it is more safer in a structurally normal heart. We don't have dofetilide. That's the safest one. And for a structurally abnormal hearts, still amiodarone has a mainstay. Now what we have is, for AF, mexiletine is very good drug for atrial fibrillation, especially post-op AF. Mexiletine works wonders. So you can avoid amiodarone and problems of amiodarone with a mexiletine. And of course, we select for RF ablation only very few selected cases of AF, because in AF, unlike other arrhythmias, is not a cure. We can only reduce AF burden mostly. But paroxysmal AF we can completely cure, because 80% of the paroxysmal AF are found to be pulmonary vein tachycardias, not actually AFs. They are pulmonary vein tachycardia. So if you isolate pulmonary veins, most of them get cure and will not have AF throughout. This is what we do. We do multiple points and isolate electrically the pulmonary vein area from the atrium. So that's what we do. So thank you.
Thank you very much, Dr. Praveen, for that very exhaustive and enlightening talk. I think our audience got to know that a lot of things are happening beyond angiograms and angioplasties in the heart. You saw those rainbow colors which we saw. All right. So, yeah. So we'll get back to any questions which anybody may have. Right. So for those who have joined in late, again, please join in menti.com and type in the code and ask any questions which one may have to Dr. Praveen regarding arrhythmias, etc. Okay, so how to work up VPCs in young people, Praveen?
Yeah, VPCs, it's a wide range, because you can have an asymptomatic VPC with absolutely no problems throughout life. Their lifespan will be normal, to VPCs which actually create trouble and cause cardiac arrest. So the range is very high, just like a syncope. So VPC is just like a symptom. So when we evaluate a VPC, first thing we need to localize it. So suppose an RVOT VT, outflow tract VPCs. RVOT VPCs are very common, sometimes they may remain harmless. So one thing what we do is we need to do a Holter serial. Serial Holter is of more importance. Sometimes over years, you may have even 1 point of time evaluation may not be enough in a VPC to evaluate. If they have symptoms due to VPC, if you can get a symptom correlation with VPC, then definitely you need to manage the VPC even if they are very few in number. That's how the principle goes on. So symptoms predominate first. If they are having syncope or recurrent palpitation due to VPC, arrhythmic palpitations by history, they will have palpitation followed by syncope. That is, or if they have an unexplained fall and patient comes with a ECG showing multiple VPCs, then you need to manage that VPC. So you need to act fast. But if they are totally asymptomatic, very few in number, suppose you have only, then you see the Holter and see the VPC burden. That's why Holter plays a role. You see the VPC burden, you can monitor the VPC burden over time, like 6 months Holter, 1 year Holter, especially in a structurally normal heart. Structurally abnormal heart, again you need to do a cardiac MRI to see what else is there. Cardiac MRI, to say structurally normal or abnormal heart, you need a cardiac MRI in a arrhythmology rather than a echo. Echo is not usually enough to delineate a good scar. So MRI is more sensitive. Even though you can miss scars on MRI, that miss is usually very low. RVOT area, you can miss scars even in an MRI. But generally, ventricular muscle for high sensitivity is for MRI, for scar. So if scars are there, again with BPC, with symptoms, you need to act faster. You need either drug, that again depends on VPC burden. Suppose VPC burden is of 7 to 10% or less than 10%, patient is having mild symptoms, you can manage with medications. Suppose they are having syncope, true syncope due to the VPC, again you need to ablate. Think of ablation earlier than giving drugs, because tablets may not, or drugs may not act completely. They may come in, next time what they may come is as cardiac arrest. So that you have to be careful.
Okay, so that's good. So how safe is adenosine to use in a limited resource setup?
Adenosine is, I think, available everywhere now.
How safe is it?
Adenosine is much safer than using calaptin or a beta blocker. The reason is adenosine acts only for 6 seconds. So it's very short acting drug, which is why it is very safe. It is much safer than using calaptin and beta blocker. IV calaptin and beta blocker are more, if at all called dangerous, they are not dangerous, more dangerous than adenosine. So because of the nature of action of adenosine, adenosine just acts for few seconds, after which if you have a ECG, if you have a good casualty setup, I think adenosine is much safer than using a beta blocker or calaptin. Some hospitals have taken off beta blocker and calaptin from casualty. They use dilsum. Diltiazem is okay, but calaptin and beta blocker people have taken up from casualty for avoiding inadvertent use.
So quite safe is the take-home message. How long medicine should be continued for AF, like flecainide?
Flecainide is a drug which can, we have seen flecainide use over 10 years causing changes in QRS morphology. So I don't think flecainide should be used in, especially when the patient have LVH. Even LVH is a structural heart disease. So most of the hypertensive will have LVH. So LVH goes into, from arrhythmic perspective, it's a structural heart disease. So people with hypertension, flecainide is not very safe for a long time. So probably propafenone also is not safe. Any 1C agent is not safe. The reason is, once you have a cardiac fibrosis, you can have increased incidence of ventricular arrhythmias with flecainide and propafenone.
So how do we select rate or rhythm control for AF based on, is it based on the age or?
Yes, partly age has a role in it. Suppose an elderly with AF with fast ventricular rates, rate control is one thing which we can think of. In all other cases, most of the studies, it's an old study, AFFIRM study which came, but if you see the AFFIRM group now, retrospectively, it is seen that 80% of people have crossed over. The same study, if you see the two groups, the rate control change, people have changed over time, over 10 years to rhythm control strategy. So the same study has actually changed. So any age group, rhythm control, try to achieve a proper sinus rhythm is what is preferred. Because sinus rhythm, especially in elderly, because sinus rhythm always reduce the diastolic dysfunction. Best one is for sinus rhythm. If you lose AV synchrony, definitely diastolic function is going to worsen over time. So if you ask an electrophysiologist, definitely rhythm control is best.
Yeah. Okay, if you do an ablation for AF, do they need anticoagulation and anti-arrhythmic drugs?
Anticoagulation is a must. That anticoagulation is not dependent on whether you do AF, whether you do medications for AF. It's only based on CHAD score as of now. So in a structural normal heart.
What about after ablation?
Even after ablation, there is no change. The ablation will not reduce the risk of stroke. Rather, it actually produces more scarrings inside the atrium. So anticoagulation has to continue, and that is perfectly according to CHAD score. It's not whether you ablate. Ablation is for rhythm management, not for stroke prevention.
So in occasional missing beats, so I think what is the ectopic burden which necessitates ablation in SVT, which is quite asymmetric except for occasional missing beats? So I think they're talking about when you have supraventricular ectopics. And,
supraventricular ectopics,
the ectopic
if
burden
they are
for
asymptomatic, atrial ectopics need not be managed. You can drug manage it for most of the times. Suppose they cause heart failure. Notorious are focal atrial, automatic atrial tachycardias can cause heart failure over time. They may present as heart failure. When you retrospectively see, you can see the ECG showing atrial tachycardia rather than sinus rhythm. Only subtle changes will be there in the PVR morphology. Actually, it will not be sinus tachycardia of heart failure. It may be atrial tachycardia causing tachymyopathy. In such cases, ablation helps.
So can we give amiodarone for an SVT?
It's okay to give amiodarone for atrial tachycardia which are resistant, but generally that is why to say that which SVT you are dealing with, better give an adenosine and see. And if you are sure that's an atrial tachycardia which is resistant, no harm in giving amiodarone. Still amiodarone can be very useful.
Okay, so in a patient who's medically managed for SVT, is there any difference between beta blocker versus calcium channel blocker?
Both are AV node modifying agents. So if you have an AV node dependent tachycardia, you can use adenosine, beta blocker, digoxin or CCB. There is no problem. There is no difference between beta blocker and CCB except for that in asthmatic you generally use CCB. Otherwise it acts the same with respect to arrhythmia.
Okay, so should a physician learn to know how to localize a VPC, you know, the ectopics?
It is better. It is more for us for localizing to ablate. For a clinician or an initial physician, yes, you need to localize because you need to know how you are going to manage it. Suppose, and again, as I told, suppose an LV ectopic, the patient is going to be very symptomatic due to LV ectopics are very symptomatic. Like outflow ectopics, which I showed that lady actually came with, even though their burden is less, they are going to be very symptomatic. But if you take symptom as a first thing, probably you need not localize it. You know that that is going to be a problematic thing. So if you have proper history predominates in VPC evaluation.
Okay, for the lack of time, we're going to have last couple of questions. What is a VPC in a quick way? In a VPC burden cutoff for treatment?
Yeah.
On the Holter.
One, it is two things. One, symptoms, presence of a structural heart disease or heart failure due to VPC causing clinical problems. And third is, if nothing is there, people do ask for ablation if it is more than, if the percentage is increasing. So generally we take as, suppose it's drug, even with drugs it is more than 10%, we tend to say ablation.
If a patient has got asthma, is there a contraindication for adenosine?
There is no absolute contraindication. I have given asthmatics adenosine many times in EP lab. It won't worsen the asthma disease as such. You have to manage acutely if there is a bronchospasm. In an asthmatic, it's not an absolute contraindication to give adenosine. We use adenosine for a lot of patients.
You'll go for the last question. Pill in the pocket nowadays, is there any role?
Yes, definitely they help. I always tell my patients to have a pill in the pocket, especially for atrial fibrillation. Suppose they land up in pulmonary, it is the only reason why they land up in pulmonary. Elderly with diastolic heart failure, but suppose they have AF, they need to have pill in the pocket. Elderly, they cannot even reach the hospital. That helps the patient to reach the hospital. So AF, especially with diastolic dysfunction, pill in the pocket is very useful. Either whichever drug which I prescribe, I tell that you take the double dose. Suppose I prescribe propafenone, I tell them take 300 milligram as a pill in the pocket approach. If it is flucaride, it is 100 milligram. You can give it a single tablet as a pill in the pocket.
Okay, I'll take this last question. Any change in management of atrial flutter based on typical versus atypical, clockwise versus counterclockwise?
Nothing. It is just a physiological thing that it runs inside the heart counterclockwise or clockwise. It doesn't have any other meaning. But the thing is, typical flutters are generally easier and more easily, they have cure rates more than atypical. Atypical are either due to some scars inside the atrium, post-congenital heart disease, post-cardiotomy. So they tend to recur. Even if you ablate it, their tendency for recurrence is slightly higher than the typical counterclockwise flutter. Nowadays, the classification is not typical versus atypical or counterclockwise versus clockwise. It is based on where you ablate. It's a cavotricuspid area which is called. So it's called as a CTA dependent flutter or a non-CTA dependent flutter. So electrophysiologically, that's the division.
Right. Thank you very much, Dr. Praveen, for that fantastic class on arrhythmias.
Thank you very much, dear sir. Your talk was extremely informative, and thanks for sharing your knowledge and experience with us. So for the last talk of the day, I welcome Dr. Salman again to talk about the clinical assessment of chest pain, history, ECG, evaluation, and the modalities available to us. Over to you, sir.
Thank you. You're going to see my stick again. I just bought this yesterday. Because somebody said the laser pointer will not work on this LED wall. So I had to improvise, right. Okay, you got to listen to me again. Okay, so here we're going to talk about diagnostics in chest pains and something a little different on how we're going to evaluate. So we know you have these patients coming to us with these kind of pain, pain here, pain there, pain somewhere. And the question is, am I having a heart attack? Am I having coronary artery disease? So it's a big question, and you see these TV inversions and all that. So what do we do? So approach to the patient with chest pain. So that's you. And how do we approach chest pain? How do we do it is the question which we're going to try to answer over here. Right, so the problem is, it sort of overlap as to what Sandeep said, what I said. I'm liking my stick here. Okay, it's, around 10% are mistakenly discharged from the ED because they are not diagnosed properly, and they have a significant mortality. Okay, we know, you look at the character and all this, we learned in second year MBBS or first year MBBS, and you have this chart in Hutchison which says this is that and all that. But the history is, clinical medicine continues to deceive us as to what exactly is the thing. Okay, so like for example, you have this guy who's got this severe burning chest pain of 2 days. He's having very bad pain. He's rushed to the primary hospital because the primary physician is not able to understand. Doctor does a quick examination. He wants to do a troponin and all these things. But then it's the ECG technician who makes the diagnosis. Why? Because he opened his shirt. So he opened his shirt to take, so he had this. And so he got a severe chest pain, which is, we guys don't open shirts and all that and check out these things. So you miss your zosters and all that. So, perform a good clinical examination. Dr. Hamza always tells us, always do this, do that. We never do it. But yes, right. So nevertheless, physical examination, no substitute for a detailed physical examination. Look at your chest, heart, everything and all that. Look for your pericardial rub, no substitute for that. Okay, so we have another one was the one which Dr. Sandeep showed, that small pneumothorax, again looking at a small, that was a case which I had around 10 years back. We published it in the Cleveland Clinic of Journal of Medicine because the small pneumothorax misses it. Professor Ramurthy sir always taught us this, when in an apparently normal chest x-ray, look for a small pneumothorax, right? Okay, so this guy, now we go on to how to evaluate this. 45-year-old gentleman, he's got exertion right-sided chest pain last 6 months, okay? And his baseline ECG is normal. So what do we do? So easy to tell him to go for a treadmill test. This is how we evaluate. Okay, so I'll just touch a little bit on how to evaluate in a treadmill, how to look at the treadmill. So you have this ECG here, this is the baseline, looks normal. So then you start exercising. At peak exercise, he develops some chest pain, some chest discomfort, and then look at these ECG changes. So you see that you're having some flat 2 mm ST depressions over here and in the inferior leads. So that's a significant ST depression which you're seeing on a treadmill, which is at recovery, meaning after the exercise, it starts to persist and have a slight downsloping. This is strongly positive here. It means it's very significant of ischemia. So you have flat or downsloping. So that's bad. Okay, so he needs to go for some further angiogram or other evaluation. So so what are the different changes which you see on a treadmill? You can have a rapid upsloping, meaning there is an ST depression, but it is rapidly upsloping. Minor ST depressions. Slow upsloping, that may be significant. That's usually say after 80 milliseconds after the J point. This is significant for ischemia. That is a horizontal, flat ST depression. This I'm talking about in a treadmill test evaluation. And this is also very significant. So if you happen to see a treadmill you want to analyze, this is a significant response for ischemia. The other thing is when you see evaluation for ST elevation. In a patient who has had an MI previously, like a Q wave in anterior wall, those patients will have ST elevation. But if you don't have a Q wave and you see ST elevation, this is also very ominous. So you look at horizontal ST depression, this is bad. Downsloping ST depression, that is bad. Non-Q patients who have an ST elevation, it's very bad, you know. So that's very critical. So that's basically in a nutshell what you look at the treadmill. Okay. Again, another chap who's got exertional right side chest pain. Everybody's got external chest pain. We want to know if he's having heart disease or not. ECG is no, echo is normal. What next? Okay, again, we'll do a treadmill. Okay, let's see what happens here. So this is your baseline ECG. We look at the baseline ECG, okay, it's normal, I'm seeing some small T wave inversion there, I'm going to keep a watch on that. Then I make the patient exercise. Peak exercise, what am I seeing? I'm seeing some small, probable 1 mm ST depression, a little bit upsloping, not very sure. And then in recovery, there's a quick recovery back to normal. So you look at the recovery, you look at the peak exercise. Whenever you guys see a treadmill, if you happen to see, look at that. You know, the recovery is coming back very normally, so you got to be a little concerned. So this comes under this mildly positive. You know, this is a big ambiguous business. This mildly positive TMP. We're not actually sure because the sensitivity and specificity for a treadmill is not very high. It's around accuracy of around 70-75%. So especially if you don't get those strong positive changes and you get mild positive changes, you are in a quandary. Does he have CAD? You don't know. But do you need to evaluate further? We don't know. You might need to look at multiple things like clinical factors, etc. Now what? Now what do we do? So now we have a multitude. That was the question which was asked in one of the questions earlier. What are the other modalities to look to confirm coronary artery disease? So that again depends on the pretest probability of having heart disease, meaning you have a diabetic. You have a 65-year-old diabetic, hypertensive, who's got dyslipidemia, smoker. The pretest probability of having heart disease is very high. Whereas if you have a 25-year-old guy just coming with chest pain here and there, you have a mildly positive, so the pretest probability is low. So all tests in cardiology and in clinical medicine depend on the Bayesian theorem of probability, the pretest probability. So the more the pretest probability, the more likelihood that test, that mildly positive is significant in that person. So you want to go escalate in that ladder depending on that pretest probability. So you have these things, you know, you have anatomical imaging, of course your coronary angiogram, you have a CT coronary angiogram which I'll touch upon, functional imaging to see how the ischemia, whether there is myocardial ischemic burden is there. You can have your nuclear medicine scans, your stress echocardiographies, you have cardiac MRIs, you have all these things where you can give either an exercise stress or a pharmacological stress. So CT is an interesting thing which I'll just touch upon. So this guy, so we ended up doing because he didn't have a strong pretest probability, we ended up doing a CT coronary angiogram. So what is a CT coronary angiogram? It's a very well-established tool which all of us use. So the object of the class now is to understand the various modalities which we have to diagnose stable chest pains. So you get an angiogram without the real invasive. It's an outpatient-based CT scan which is done in a cardiac protocol. It's not the usual thing. It has to be in a machine which is capable of doing a cardiac CT protocol, minimum of a 64 slice or upward. And then you have to lower the heart rate and you get this. So here you see that it's all normal. So once you see a normal this thing, so you're able to see each artery. So this is your left artery descending, this is your right coronary. You can actually map it right from start to bottom and you get a pretty good picture in an outpatient basis, which is quite reassuring, right? So this is all images of all the arteries which you can get. So who all to send for a cardiac CT? So when I said this is the low-risk patient or asymptomatic patient or mildly kind of those kind of things. If you have a high-risk patient, like I said, 65-year-old, diabetic, hypertensive, dyslipidemia, smoker, high-risk factors, and who have significant chest pain, you don't want to do that. You want to directly take him up for an invasive coronary angiogram. The low-risk guy, young age groups, lesser risk factors, you have good. So who have equivocal stress test. So what is the thing is it's got a very high negative predictive value. Very high negative. So if the CT coronary says that there is no disease, it's finished. Chapter closed, you stop your evaluation there. So you have a normal coronary means it is normal, right? So another thing where we use it in post grafts. In CABG patients, 10 years after 5 years, you want to evaluate. You don't want to poke him and hook in all those grafts in an angiogram. For evaluation of post CABG is fantastic. And of course, calcium scoring. Calcium scoring is not the same as CT coronary angiogram. Calcium scoring is basically just doing a plain CT, which looks at the calcium burden in the coronary arteries. Okay, so you have this 45-year-old doctor. Okay, so he's got a recent arthroscopic knee surgery, but he's having chest pain postprandial. He wants to know what to do. ECG is normal, echo is normal. So he can't do his treadmill. Now what to do? So we do a CT coronary angiogram. So we do a CT coronary angiogram, look at that. Look at this is the left anti-descending. You have a critical LAD disease in the proximal LAD disease. We took him up for an angiogram. You can see that very critical, life-threatening disease there. Immediately we did an angioplasty, and there you go. So it's a very easy test to understand. It's a pre-screening for, especially for people who we don't want to push him for the angiogram per se first. But yeah, so he's a young doctor, not so the initial screening test, it's good in those indicated patients. This is another CT angiogram showing a very tight, this is the CT and the correlate in the invasive angiogram, which is matching in the angiogram, right? So as I said, in post-CABG patients, it's very helpful. In one shot, we can actually get all the native 3 coronary arteries as well as all the grafts. So for those of you who are not very familiar, these are how grafts look like. So this is the left internal mammary artery, which is going all the way from the subclavian, going down and supplying the LAD, which is patent. And you have an SVG graft, which is coming from the body of the ascending aorta and going on to the RCA. So you can beautifully see these CABG grafts in one shot, where you can assess the native vessels as well as the grafts. So it's a beautiful tool for this thing. So this is showing multiple grafts over here. You can see the SVG grafts going to the diagonal as well as the circumflex artery. Okay, what is calcium scoring in a nutshell? Okay, this is, as I said, it's a plain CT, which is, you have a software for calculating. So there's no contrast. It's a screening tool for measuring the atherosclerotic risk burden. Underline, just for measuring the atherosclerotic risk burden. So you're looking at these calcium over here, quantified. So in the intermediate risk patient, you want to quantify. So you come up with a score. There is it's called an Agatston score. Mild, moderate, severe, more than 400 is very severe. So this gives you your atherosclerotic risk profile scoring. What does that mean? It means like, I am diabetic. That is score 1. I am hypertensive. That's score 2. I am a smoker. Score 3. I have a calcium score high, score 4. It adds to your global atherosclerotic risk burden. So if you want to, basically want to know whether you want to put this guy on a statin or not, you can do a calcium score as an OPD basis test. That's what it means, right? It doesn't tell you if it's got a stenosis. So we have studies to show that the more the calcium score, the more the annual mortality or risk of MI. Okay, the other advantage of CT is actually, you can actually, it's more than a luminogram. Like for example, in this angiogram, how it is better than an angiogram. In this angiogram, it looks normal. I would say it's probably normal. But the CT correlate of that is actually that there is some positive remodeling. That is, the vessel is actually big. There's a lot of plaque deposit over there. So here I might say it is normal and just send him with nothing. But here I'm going to give him statins for plaque reduction. So that's an important thing which one can see, plaque burden in this thing. So similarly, of course, for dissection is the class 1 indication to diagnose aortic dissections. No doubts about that. This is a descending Stanford type B dissection. And of course, in the chest pain evaluation, pulmonary embolism. So you can see this pulmonary embolism sitting over here, this big chunk. This is your main pulmonary artery, which is bifurcating into 2, and the major chunk of pulmonary embolism over there. There was an initial big promise for CT for doing the triple rule-out test. You know, if you have a chest pain with a non-specific ECG to diagnose between these 3, the dissection, coronary, as well as pulmonary embolism. Not very fancy because the protocols are slightly different, but yes, you can keep that in mind. Okay, so that was CD. What else do we have? What else do we have in the armamentarium to diagnose CAD? So this is the world of nuclear medicine. Fantastic. So we guys over here in MIMS are all spoiled for choice because we have all these modalities with us. So we have a fantastic nuclear medicine department which gives us all these options. So here what we do is we inject tracers and put them on an exercise program or a pharmacological program. So we have rest and stress tracers. For example, these are the rest tracers. If you can look at this, so this is how. So this is the LV border. Just like to see in different views. This is the circular short axis, long axis view. So this shows normal rest perfusion. All the orange shows normal perfusion. Then you put him on a treadmill and then give the next tracer and image him. You can see that after stress, the perfusion which was over there is not now happening over here. The perfusion which is normal at rest is now not happening over here. The perfusion which is happening at rest is not happening here. So this shows stress-induced ischemia. So it is one up from your treadmill. It's the same treadmill, where you're looking at only ECGs, but here you're looking at functional visual imaging where you're going to get more data. So this is perfusional imaging. So this is how differential, how an LED disease would look like. So this is a normal. So this is the apex. You can see the apex is having a lack of perfusion, right? Lack of perfusion compared to that. Lack in the anterior areas. Now how a circumflex artery defect would look like, lack of perfusion over here, how a multivessel disease pattern might look like. So very easily available tool. So we send for stress myocardial perfusion. So like for example, I told you that example of the 45-year-old doctor who's got some chest pain. Fantastic stress, send for a stress. So he's not able to exercise, you put him on either some kind of a dopamine stress or adenosine pharmacological stress. We also have adenosine. So these are all different images on how we can actually map out different perfusion on stress and this thing. So just like how I mentioned earlier. So this is, we also have one up where we can measure metabolism. We're using PET CT. I won't get into the details of that, but we are going one up where we actually see myocardial metabolism and map it. For example, this patient in the initial CT, you can see the calcium, the LED, lots of calcium. So he's got a very high Agatston score. So one might think that a very high score means very high stenosis. But no, look at his rest and stress images. They're all bang normal, right? They're all bang normal. So he's got a lot of atherosclerotic burden, but he's not developed the stenosis inside the coronary arteries. He is a atherosclerotic guy, but so this is how it goes. So this, the physician sends for a calcium score. He gets a very high score. So there's a flag. So you put him on a high dose statin, but he's asymptomatic. Does he have stenosis? He's scared. So you can put him for an elective OPD basis test like this and send for a perfusion imaging. It's a functional imaging. And the functional imaging shows that the stress images are also good. Finished, case closed. So he's got, you put him on a statin, but that's it. You don't need to go for an invasive angiogram. So this is how that works. This is how that principle works, okay? Now this is another person where you can see the rest and stress images are different. The rest is full, but the stress is bad. So you had a significant LAD disease, which was stented. Okay, so out of that, so now we'll look at another thing. So this guy has got chest pain, elderly chap who's got right-sided chest pain. Since 2 weeks, ECG is looking sort of okay. This is the X-ray. What next? Yeah, so what next? We can do a lot of things, but this X-ray's got a lot of things. So we do an echocardiogram because in this hospital we have the luxury for doing that. So we do an echocardiogram. And this is similar to what Dr. Sandeep showed a little earlier. For those who are not very well aware, this is the left heart and this is the right heart. It should be the direct opposite. The right heart should be small. You can see that the right heart is really big and it's dilated and it's got a lot of tricuspid regurgitation. So something's wrong with the right heart. There's RV dysfunction with this thing, significant RV dysfunction. So I'm not thinking of MI now, so there's no chest pain. So there's something wrong over there. And then I look back at this X-ray and then I find out that, yes, there is some significant pulmonary oligemia happening over there, which is something which we don't look. We think of rotation and all that, but that's pulmonary oligemia. And therefore I'm thinking of pulmonary embolism. Yeah, I'm thinking of pulmonary embolism. And so I'm thinking of pulmonary embolism, so I need to do a CT pulmonary angiogram to confirm. But then the labs come out as creatinine 4.5. Potassium is high. So now what do? So that's a problem. So can I give that 100 ml of contrast? No. So that again, we used our nuclear medicine department where you can do a VQ scan, a ventilation perfusion scan. Again, we've all learned it in all our theory books and all, how much of us actually know it's available and how many of us actually know that we can actually do these things. So we did the perfusion scan. I don't have the ventilation scan with me. But see these patchy defects over there, which is suggestive of pulmonary embolism. Suggestive of pulmonary embolism. So this is how a normal lung perfusion would look like. A lot of, what is that color? Purple colors. And when you have multiple perfusion defects, this is how it would look like. You actually match it with a ventilation scan, meaning if there is a ventilation perfusion mismatch. This is how it is. So ventilation perfusion mismatch means that is the ventilation is normal, but the perfusion is abnormal. That is a mismatch such as a pulmonary embolism. If the ventilation is abnormal and the perfusion abnormal, that is a match. This is not suggestive of pulmonary. That's something like a pneumonic consolidation or some other kind of this thing. So it's very good in pregnancy and CKD patients like we saw where we can do that. We also use very frequently cardiac MRI. Okay, I think my videos are not running, unfortunately. Bad luck for you. Right, so whereby we can, this is usually we use it in structural heart disease, where I want to use for cardiomyopathies, cardiomyopathy evaluation, etc. I can look at chamber quantifications, regurgitations very beautifully. And we also can use it in coronary, where we have stress protocols for, even for cardiac MRI. A little bit more cumbersome than the other ones, but yes, nevertheless, we can use it for evaluation of masses. You can see that big mass sitting over there, which is a left atrial myxoma, very beautifully imaged in cardiac MRI. Right, so other modalities, other imaging modalities, what we usually use in cardiology. A 3D echocardiogram, okay. So this is, I mean, again, I just thought I'll show you some fancy pictures because this is what we routinely do in our day-to-day clinical practice. This is how a mitral valve looks like in real time in our echocardiogram machine. That's how a normal echo looks like in 2D. This is how it looks in 3D. We can measure mitral stenosis areas, regurgitation. This is the regurgitation to assess mild mitral regurgitation. This is how an aortic valve looks like. Like Dr. Renu mentioned, this is how an ASD looks like in 2D. You can only see one plane, you know, the 2D plane of the cutoff, which you can see is a 2. But when you look at it in 3D, so this is how you're actually looking at it from the left atrium. You can see that hole sitting over there. That's the atrial septal defect. Okay. This is an LA myxoma, huge LA myxoma. This is the left atrium, this is the left ventricle, a huge myxoma which is getting into the left ventricle. Okay, so this is again an atrial septal defect which I showed, but how it looks in 3 dimensions. We actually thought it was 1. When I do a 3D echo, I actually say that I get more. So it's like a buy 1, get 2 free. A 3-dimensional echo helps us to actually visualize the anatomy. This is another atrial septal defect, when I looked at the 3D. So this is, I'm looking at it from the right atrium, you know. So this is a glass view of a real-time view. This is live. Imagine you're sitting in the right atrium and the left atrium is just behind this wall and there are these 2 holes sitting over there. Looks good, huh? Right, yeah. Thank you. Anyway. So the chest pain, back to chest pain. So the young lady who had sudden chest pain in dyspnea, okay? So the young chest pain, this is what the echo showed. And so actually, I'll give you the diagnosis. You might not understand. This is a ruptured sinus of Valsalva aneurysm, okay? So sinus of Valsalva, my video is not running, it looks like this, you know? It's a sinus of Valsalva is this bulge of the aorta. It actually aneurysms and ruptures into the right atrium. And this is a big medical cardiac emergency, which I just wanted to show you how the 3D echocardiogram looks like. So this is the aorta, and this is it's actually supposed to be only the circle, but this outpouching, which you can see in 3D, you know, which is actually outpouching, this is the right atrium, and you can actually measure the dimensions of that. And then we eventually ended up putting a device. This is a device. Traditionally, it was all surgical closures. We put in a device and successfully closed it for that lady, and she's doing quite well. This is a small mass in the left ventricular outflow tract. That's how it looks in 2 dimension. But if you look at it in 3D, this is how it looks. You can see that ball hanging there, very artistically beautiful. But yeah, it's a benign tumor sitting there. Just to show the gamut of things which is available today for us. Another thing which I would like to say, quickly suggest, is one thing what we use is contrast echocardiography. Another thing which we in our department use, I'd like to, we see this kind of echoes when we're not able to understand images, okay? So then we use this commercially available contrast which we inject and do this. We are happy to say that we are one of the very few centers in the country to routinely use contrast echocardiography on a very regular basis for our cardiographic images. So once once we put contrast echo, this is how my echo looks like, where I can get beautiful images on and understanding how my LV looks like. I can understand endocardium, I can understand appreciate systolic thickening, and also myocardial perfusion. So the amount of this contrast which is getting into the myocardium also I can understand through contrast echocardiography. So suppose a patient comes with chest pain, trop negative, ECG is nothing great, the echo looks normal. So you can, the echo looks normal. We can actually, okay, I think that slide got missed. Okay, we'll go on to the next case. A 65-year-old guy with CABG, chest pain, non-diagnostic ECG, putting in a contrast echocardiography, you can see this is how it looks like in the late refill. All the myocardium is filled with contrast. Just concentrate on the myocardium. But in the early refill, there was slight small decrease in uptake over there. So this gives us a clue, even if the echo is normal, that this patient could be having a critical lesion. Young lady who had stroke with LV dysfunction, okay, was from our neuro team, had a stroke with LV dysfunction. We initially opined as stress cardiomyopathy and just dismissed. But after 2 weeks, since she was not improving, we took her up for a contrast echocardiogram, and then we were surprised to see these findings. We saw that there is some apical wall motion. We saw that there is a filling defect over here, which is such of a thrombus. And we saw some lack of uptake, this black areas which you're seeing here, which changed the diagnosis. Look, you can see the black area here. It's supposed to be white, but it's black, which changed the diagnosis and made it ischemic cardiomyopathy. The patient had an LV apical clot, and because of that, she developed a stroke, which changed the whole management. I took her up for an angiogram. She had severe triple vessel disease. We opened up her LAD, and she's doing well on follow-up. Similarly, severe back pain. Somebody referred to rule out aortic dissection, where before we did a CT, the echo was looking normal. To rule out aortic dissection, we took him up for a contrast echo, and we saw that the patient had an infralateral uptake loss in the myocardium. So he had a tight OM lesion for which the PCI was done. Stress cardiography, echocardiography is the other modality which you can send. Our routine stuff which we routinely do, dobutamine stress echo, whereby patients are put on dobutamine and look for wall motion abnormalities and systolic thickening. There also we use contrast echo so that we can actually look at perfusion abnormalities also is what I would like. So just to touch that, we have a lot of modalities where we can appreciate wall motion, systolic thickening, as well as myocardial perfusion. So stress echocardiography, again, an outpatient test where one can use. So this is a lack of uptake on the dobutamine stress, which showed that the patient had a critical LAD lesion. Okay, so that was just a nutshell to wrap up all the modalities what we have, just to show that all chest pains are not MIs, all anginas do not need to have typical presentations. You need to have a broad index of clinical suspicion, like, the herpes zoster, which you saw in the first case, and one should know all your knowledge of all the modalities which one can use to diagnose. Thank you very much. All right, so if anybody has any questions, one can proceed. And that was the last talk before we wrap up for today's this thing. We have a final quiz coming up. Instead of typing, you can also speak up, there's not a problem. We just introduce this platform in case anybody has any issues in speaking up, that's all. So nobody has any questions, so nobody usually has any questions. That's why I kept this platform anyway. Okay, so what are the indications for contrast echocardiography? All right, I'll just get, contrast echocardiography we use for diagnosis of unknown cardiomyopathies, look for LV apical clots, and for endocard, better if you don't have a good image. The echo is, I'm not able to see at least 2 to 3 contiguous segments. I need to put in a contrast to get a better image. So we use it for a lot of things in our department. We use it for a lot of purposes, but because from more of an academic perspective, but how to treat based on calcium score. Just give them 1 second. I would like to say that a calcium score, I'll just try to get this. What is a calcium score? So calcium score is an add-on to a global cardiovascular risk prediction. Like I wanted to say, calcium score does not say that the patient has got stenosis. It just says that you have an atherosclerotic burden, so you may need to be on a statin, that's all. If you have a high score, you may need to be on a statin. What is the specificity of VQ in diagnosis? It's not in pulmonary embolism. What is the accuracy of a VQ scan in pulmonary embolism? It's not as high as the CT pulmonary angiogram, but we get a lot of information in that patient. In today's clinical practice, nobody would send for a VQ scan unless you have these kind of issues like CKD, creatinine issues, or pregnancy. Is CT angiogram and other tests feasible for a middle-class man? Yeah, it's feasible for any class man. What does middle-class man mean? Okay, economic, I thought age. Okay, sorry. Middle-class man, yeah. If one is referring to cost, it's not a costly. Like for example, it would cost similar to an angiogram. Like for here, it just costs 10K. It's a very good screening tool to understand atherosclerotic burden in those patients where you want to know family history of heart disease, very strong family history of coronary artery disease, but I'm asymptomatic. I seriously want to know what's going on inside. Do I have a lot of plaques developing, a lot of plaque building up? Do I need to be on a statin? Do I need to aggressively risk stratify myself? Yeah. Should we start on ecosprin statin for mildly positive TMT? That's a very common thing which we see in day-to-day practice. That's probably because of more of a social problem rather than, because we want to give something. But there is no indication to do that unless we are actually sure of coronary artery disease, See, a mildly positive TMT does not stop there. You have not diagnosed coronary artery disease. You just think you have coronary artery disease. So then you say you go for a CT or a coronary angiogram. And then the person, then, because for social indications, you start ecosprin AV and then send it off. But then you start advising some other tests and then this guy is advising a lot of tests, but I don't have any symptom and that. So there we start up ecosprin. But then actually it's not theoretically correct. Why are you putting him on a bleeding risk? You actually have to up the game. So, and try to confirm that particular diagnosis in mildly positive TMT. Mildly positive TMT is not equal to CAD. Very often in middle-aged ladies, most of them have mildly positive TMT and they will not have any CAD whatsoever. So, if economics were good, we could probably do all of these things like, like a stress nuclear myocardial perfusion imaging, a CT coronary angiogram. All of these things would actually be relevant before putting him or her on a statin plus aspirin. CT versus invasive CAG, which is better? It depends on who. As I said, the pretest probability. If any of the persons in this crowd having chest pain, a CT might be better, which is not very, if it's not very symptomatic, mild chest pain, mildly positive TMT. But anybody in a senior crowd who's having more risk factors, more pretest probability is high with typical symptoms, it goes for invasive CAG, no doubt about that. CT is a screening tool. It's a screening tool when your suspicion is not very high. It's the low to intermediate risk person who you're going to do CT. Because there's no point in a person with typical unstable angina to do a CT and then repeat another contrast load to do an invasive coronary. You should escalate directly. A patient with 40% occlusion on angio 2 years back, how fast does the occlusion progress? Like 90 to 100. When to do next elective angio? Yeah, so 40% disease, we put on medical management. So statins is the mainstay of therapy here. You put on statins, the regression rate for statins is actually only around 20 to 30% of regression happens. So it doesn't regress, but at least we want to keep it from non-progressive. So 90 to 100 is, if you're really messed up and you're not taking care of your risk factors like smoking, diabetes, hypertension, dyslipidemia, etc., then the progression is likely to be high, especially for diabetes is how we see a rapid progression. What does minor CAD on angiogram mean? On angiogram, minor CAD means that a normal angiogram looks clean, like this, smooth luminal contours, but if you have irregularities, which suggests that there are plaques sitting here and there, that is minor CAD. So what is the importance of minor CAD? That is the patient I am going to give a statin to prevent progression. A normal clean coronary doesn't get anything. But minor CAD, the hemodynamically he or she is okay, but he should be on a statin because he or she is the person who is going to get 5 years from now some kind of significant stenosis if you're not taking care of it. So that person requires a statin. So what is the statin role in mild plaque? That's just what I mentioned. Is bubble study an imaging modality? Yes, it is a modality. It is the original type of contrast which you meant. So take saline, agitate it, and make bubbles, micro bubbles in that, and then flush it. So we use that for looking for shunts, like, right to left shunting and all that. That's the ideal original contrast. What I mentioned is commercially available contrast is available. It's expensive modality, but bubble test is used in certain cases, like in right to left shunting. We use it in CLD patients to look for pulmonary AV fistulas. This is what we do. Okay, does dose of statin for preventing CAD? Yeah, so you have mild, moderate dose. It depends on the risk factors over there. What is the importance of bubble contrast? Is endovascular or coronary ultrasound better for mildly positive TMD? Coronary USG? Well, that's a very interesting USG. Coronary USG. I've not heard of that USG, but okay, I seriously don't know what that means. But for mildly positive test, coronary angiogram, yeah, coronary angiogram, if somebody wants. Okay, yeah, IVAS, but yeah, IVAS comes after a coronary angiogram. Yeah, so meaning, so the question is not, I thought about IVAS, but then see, IVAS is intravascular ultrasound for those who's not this thing, but coronary, for mildly positive stress test, you once should think of whether you want to do an angiogram or not, and then an angiogram, and then whether you want to have an intermediate lesion and then do an IVAS. That is to see whether the lesion is intermediate or significant. But yeah, I mean, that's not a take-home message that IVAS for a mildly positive TMT. But yeah, IVAS is okay, we'll put it in another. What is the indication for intravascular ultrasound? The indication for intravascular is to determine the intermediate lesion. So you have these 60 to 70% diseases. How actually is the luminal area available in there is what we do an IVAS for. So in that, so it's not for the TMT as such. For intermediate lesions on a coronary angiogram, we can do an intravascular ultrasound. High dose statins means, and when you advise high dose statins means your 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin. It's indicated for patients with high risk CAD, patients who have undergone an ACS, a procedure like angioplasty, post CABG, significant peripheral artery disease, all should get high dose statins. Fabulous, thank you very much. Aspirin versus clopidogrel after angioplasty as a single antiplatelet, which is preferred. After angioplasty, for 1 year, you have to take dual antiplatelet. After that, you can choose to switch over to aspirin or clopidogrel, whichever is preferred by the physicians. Okay, again, for the want of time, thank you very much for that. We're not finished. Don't clap as yet. You can pause your clapping. You ought to still see me again. So we are going to go for the quiz, okay? Because you guys are all bored. We have to have a quiz. Right, okay, so again, it's the last round, last 15-20 minutes, we're going to go for a quiz and then we're going to go for wrap up for lunch. Okay, so for those who are not in the platform, everybody please log on to menti.com, put in the number and then show us some thumbs up to show that all of you guys are in. Everybody in the back row can also get in. Menti.com on your internet browser. And I hope everybody's seeing the screen. If anybody is on the previous, you can refresh your browser. If you can refresh your browser, you'll come back onto this screen. 86287544 or the QR code, menti.com, enter the code so everybody will be on this platform. Anybody who's not been able to access, please raise your hand. One of our team will help you. Anybody who's not able to access the particular, please feel free to raise your hand. Menti.com, go to menti.com on your internet browser. It's very simple. You don't have to press www and all, just say menti.com and then put in the code. Menti.com and put in the code. Thank you. So if you're on my same platform, you will probably be seeing this on your screen, on your mobile phones. Okay, so that's good. So I hope most of you are in this thing. So this was our question slide. Okay, no problem. I'm just going to go ahead. It's quiz time. Okay, so everybody get set for your quiz time, right? Okay, so lots of flashy colors. That's just to wake everybody who's sleeping. Some colors so that all your visual stimuli is all activated. Okay, everybody's active now. Okay, now you will soon be prompted, not yet, you will soon be prompted to enter your name and then submit. Okay, so everybody, you're going to get ready right now. Okay, so put in your name and submit, enter submit. Okay, put in your name and submit. Okay, so these are all our players. Okay, these are all our players. We have very colorful players today in our quiz. Okay, rapidly put in your name and submit. Okay, very good, very good. Everybody's joining in. 89, 90 people have joined in. We're having a massive quiz. Mr. Lukman sir. We have our eminent people from our management sitting here who have supported us fantastically during our venture here. So 89 players are ready. We're going to start our quiz. Everybody get ready. Oh, more people are coming in, 91, 92. See, they're all fighting for space inside. Yes, they're all fighting for space. We have 22 questions and we're going to start the quiz right now. All very, very difficult questions are coming up. So very, very difficult and challenging questions. How many sessions of Back to Basics have taken place in the past? Okay, 2, 3, 4, 5. How many sessions of Back to Basics have taken place in the past? So you have to choose from the multiple choice questions, and yes, 61% of people answers, too much work pressure. Okay, have answered correct. Yes, we have had 5 sessions in the past. You are attending the 6 sessions. Thank you very much. Okay, we'll go on to the next question. Okay, just to understand how this works, we'll understand who got that first. So, who is on the leaderboard chart. So Kristen Sunny is leading. He was the fastest in answering this correct answer. There are people, Riaz and all is on the lower end, but yeah, you can match up, not worry. Okay, so we're going to go to question number 2. Okay, answer fast and answer accurately. That's how you, which is the capital of Kerala? Okay, it's a very difficult question here, and the options are Koilandi, Vadagara, Attapadi, and Thiruvananthapuram. So there are 4 questions, and you have to answer it accurately and fast. Okay, and there are few people who have answered otherwise also. But yeah, nevertheless, let's see the leaderboard. Let's see the leaderboard, who is fastest again. Kristen Sunny is still leading in terms of being the fastest and the most accurate in this particular business. Okay, we're going to go to question number 3. More tough questions coming up. Answer fast and answer accurately. Which is the capital of Australia? This is a difficult question. Okay, you have Sydney, Brisbane, Canberra, or Melbourne. Sydney, Brisbane, Canberra, or Melbourne. Which is the capital of Australia? Right. So let's see. We're going to get interesting answers, I'm sure. And the answer, everybody answered 42, is Sydney, which is the wrong answer. And actually, it is Canberra. See, you thought I was making a joke all this time. No, you don't know your geographies, right? So the answer is Canberra is the capital of Australia. And so we have learned something in today's CME that this is how it is. So the leaderboard should change, I think, now, where Siddharth has now come up on top. Vani was fastest here, but she doesn't have a score, but Ray becomes on top. Okay, and question number 4. Okay, answer fast to get more points. The population of Kerala would be, okay, this is again, 1.3 CR, 2.3 CR, 3.3 CR, 4.3 CR. Okay, this is just a general, to get the ball rolling. Okay, people don't need to know that, but yeah, everybody has voted. Let's see what's the answer. what everybody has voted. Yes, everybody has got it the correct answer. A lot of people thought it's otherwise. It's okay, no problem, no problem. It's everybody to get fast, and so you see Anantha Krishnan, doctor, has been a little fast here, and so the leaderboard is going to change. So whereby he has gone on top, and Vani's come on second, but Sanal was fastest, but still, nevertheless. Okay, the last question in this funny, stupid round of questions. Lage Raho Munna Bai is a very famous movie. Okay, so the question is, for this is, okay, all difficult questions. Which profession does Sanjay Dutt fake in the movie Lage Raho Munna Bai? Which was the profession? Was it a doctor? Was it an engineer? Was it a history professor? Was it a software engineer? Very, very academically relevant questions we are asking today for overall enlightenment. Okay, so a lot of people thought it's doctor. That was for Munna Bai MBBS. So all of you got it wrong. For Lage Raho, he was a history professor, and therefore, so you're not watching your movies also properly. So there you go. Okay, so we go on to the next question. I hope we have some really academic questions now. Oh, this is the last, okay. Dulquer Salman's father is Suresh Gopi, Mohanlal, Mammootty, or Salman Khan? Who is Dulquer Salman's father? Okay, this is the last of this round, I think, don't worry. Yeah, so, okay. So there are a lot of people who thought it's Suresh Gopi and Mohanlal. Okay. Yep, so we have, again, the leaderboard changing. Almas is on top, Anantha Prasin has come on top. Parvati was fastest here, but because of lack of accuracy in the previous rounds, this is how the fast and accurate is how the scoreboard works, okay? Now for some serious stuff. Okay, enough of jokes, yes. Now we're going to do some learning. Right, here goes. CT coronary angiogram has excellent what? What? I mentioned it has what? Positive predictive value, negative predictive value, excellent sensitivity, or excellent specificity. What does it have? So we mentioned this particularly. What does it have? Yeah, see, CT, the computer doesn't like serious questions. It likes only funny answers, okay. Okay, so I think that's a net thing. No problem, no problem. So we will refresh that. It has to be a net issue. Press on refresh. Yeah, so the answer was negative predictive value. I'll just present this. Yeah, so many of you got it wrong. As I mentioned that it's positive predictive value, meaning when you have mild stenosis, it can over-predict, it can under-predict. But if it says there's nothing there, it's nothing there. That's what is meaning negative predictive value. If it says it's no disease, it's very accurate in that. When it says it has some disease, you don't know it. If it says 30%, it could actually be 50%, it could be 20%. So there is an issue there. But when it says there's nothing there, it's nothing there. That's why it's got excellent negative predictive value. So that's what that means. Okay, so that's that. So the leaderboard for that goes like, so I think Prasin got that accurately, and the leaderboard changes like that. Don't worry, the leaderboard will continuously change, but we will have something. Get ready for the next question. Answer fast and answer accurate. In a person with diabetes, I request Dr. Bijoy, Dr. Sandeep, our speaker, Dr. Praveen to come up. Siju, can you answer some of this thing? In a person with diabetes, chairs here. A normal ankle brachial index excludes diagnosis of PAD. Elevated brachial index exclude a diagnosis of PAD. Pulse oximetry should not be used to diagnose PAD. Okay, I think that was a little fast because I mentioned that. It's okay. So, what is correct? Meaning, a normal ankle brachial index alone excludes, no. So, that cannot exclude, that is not the right answer. You can have, it's not a perfectly accurate test. An elevated ankle brachial index alone, that also cannot exclude. Pulse oximetry should not be used, which is correct. A lot of people put in a pulse oximeter on your toe to see if the pulse waveform is coming. That is not recommended. Okay, so I'll skip the leaderboard over here because we don't want to get excited too much about who's winning. We'll go on to some questions. Right. So let's see. Ankle brachial index. Which statement is correct for the ABI index? Okay. So it's the ratio of the highest arm by highest ankle. It is done in supine position. Automated cuff is better than manual, which is correct. Get some chairs for Dr. Bijoy and this thing, please. Somebody, Mirsad, 2-3 chairs over here in front. Dr. Bijoy, Dr. Sandeep, please come in with cordless mic, please. Cordless mic. Okay, it's done. The correct answer is that it's done in supine position. Or we can sit over here on the platform here. We'd like to everybody see. So, Dr. Bijoy had discussed that it cannot be the highest arm to ankle because it's ankle brachial index, right? It's not the brachial ankle index, and automated cuff is not preferred. So you actually do
Doppler testing.
manual.
Basically by Doppler assessment of the systolic pressure.
Manual, and it's preferably done in the supine position, correct. So this is how it's measured, Dr. Bijoy, supine position. We're going to take some take-home messages over here. Avoid the wounded zone, 5-minute rest. It's measured by a Doppler probe. We take a Doppler probe, we manually look at your anterior tibial and dorsalis pedis of each leg and the brachial artery. Automated cuffs are mostly not valid, and the ABI is calculated by dividing the highest ankle to the highest arm systolic blood pressure. One more chair. Please come up. I invite our respected speakers, Dr. Praveen, Dr. Sandeep, and Dr. Bijoy, sir, to come up on stage. Yes. Okay, so that's how that is done. So this is how that, you actually take a manual probe to see that. So this is, you understand that you don't take this thing, you take manual probes actually. Correct. So the leaderboard for that is, Bijay had come up in between, but Burhanuddin was the fastest over here. So Bijay is coming up, that's good, keep up the good work. So the next question we have here is, in PAD, best medical therapy involves, okay, which one? Statins when lipids are high, physical exercise when symptoms are very severe, smoking cessation for all patients with PAD, which is correct about medical therapy for peripheral arterial disease. Okay, everyone has voted. Dr. Bijoy, statins?
Statin should be given to every patient.
All patients of peripheral arterial disease, and physical exercise also?
In severe cases, physical exercise is not advisable.
Yes.
It needs a revascularization actually.
Yes. So otherwise, in all patients, we would like to give them, so these are the class 1 recommendations that smoking cessation is good for everybody, physical activity is good for everybody, statins for all patients, and you need to reduce the target's LDL to, less than 70 in peripheral arterial disease. So you need to be really low in such these things. The leaderboard is progressing again. Dr. Prasin is doing well. Dr. Bijay is doing well. Anthony is doing well. Sanal was the fastest. But again, Prasin Pradeep is leading the room. Okay, so we have a 12-year-old with chest pain. There's something which Dr. Sandeep discussed, has some changes on the ECG. Okay, and what is the question for that is, look at your device. We'll look at the ECG. What does it show? Is it Al-Kappa, which is an anomalous left coronary artery, juvenile pattern, or anterior ischemia? I saw T-wave inversions in the anterior leads. Is it anterior ischemia? Is it a juvenile pattern? Is it Al-Kappa? Al-Kappa is anomalous left coronary artery from pulmonary artery. A lot of people have answered correctly. Dr. Sandeep just mentioned 2 words on this response.
We have discussed about the T inversions in benign, which is benign for young females. It's a juvenile pattern.
So juvenile pattern means in pediatrics, it's a normal phenomenon to have T-wave inversions in the anterior leads. It's not anterior ischemia, it's not Al-Kappa. Okay, I'll skip the leaderboard here to make it suspense to who's leading. I want to keep the suspense. We have 95 people on the quiz over here. Stage 3 Fontaine of lower extremity disease is something which we'll discuss now, just even though, is it asymptomatic, intermittent claudication, ischemic rest pain, or gangrene? Fontaine classification is a classification of peripheral artery disease. Which stage does stage 3 refer to? It's not very important, but I just wanted to familiarize you with this. So the correct answer is ischemic rest pain. Dr. Bijoy can just tell us about these 2 things, just in quick brief.
Fontaine classification symptomatic is 1, class 1, and the ulceration 4. And
4, yeah. In Rutherford, there are only 3. So just to understand that there are 2 classifications at least, that somebody tells about Rutherford, somebody tells about Fontaine. You don't have to mug it up and all, but these are commonly used classifications for understanding, okay? I'll skip the leaderboard again, so as to keep the suspense. Okay. A large VSD should be closed by, I think Dr. Renu madam is not here, before the first year, before 5 years of age, before 10 years of age. Sorry. So when should a large VSD be closed ideally? I think Dr. Praveen can touch upon this once everyone has voted. A lot of people have answered before first year, a lot of people have answered 10 years. Would you like to touch upon it?
The thing is, for a small VSD, probably we can wait and watch up to a maximum of 9 to 10 years.
Yeah.
But if it's a large one, or if they are causing hemodynamic issues like dilatation, recurrent pulmonary edema, or recurrent respiratory infections, then they need to be closed earlier, preferably before 1 year.
Yeah, before 1 year, because otherwise you'll get into Eisenmenger syndrome. After that, they'll get into a decline in symptoms. A lot of people think that they have become okay. That's very, very wrong. Very important message. They have to, otherwise they get into Eisenmenger syndrome, then the game is lost. Very important message over here. I'm going to skip the leaderboard. Okay, and the next question. In case of incompressible arteries or ABI more than 1.4, which is recommended? Toe brachial, Doppler waveform, pulse volume recording, all of the above. So you have an ABI where you're getting very high values, 1.4 or more. What do you do? Yes, the correct answer, Dr. Bijoy.
all of them are useful because toe brachial index can be used, and Doppler waveform, everything can be. Basically, they are non-compressible arteries. Toe arteries are not affected by arteriosclerosis.
Correct. So arteriosclerosis, thickened arterial wall, ABI becomes sort of not very accurate, and then that becomes a problem over there. Very good take-home message over there. Okay, so we have Dr. Praveen's topic over here, a 35-year-old guy with recurrent palpitations. Have a look at the ECG. This is something which, similar to what Dr. Praveen showed several times in his presentation. What is the diagnosis is the question. Okay, we're just going to come up on your screen soon. And what is the diagnosis? Is it, look at your device. Is it functional palpitations? Is it Wolff-Parkinson-White? Is it right ventricular cardiomyopathy, or is it hypocalcemia? It's an easy question. Dr. Praveen, would you just like to say a few words on that?
Basic thing is when you note a short PR, definitely it points to a pathway.
Yeah.
So it's a WPW.
Yeah, so short PR and a delta wave, you think of WPW. We're not thinking of RV cardiomyopathy. We're not thinking of hypocalcemia. And so I'm going to skip the leaderboard. Okay, so we're going to play a small game here. we just put on your mobile phone, put a pin on the delta wave. Let's see how many people get the delta wave. You can put a pin. Yeah, let's see if everybody gets the delta wave. Let's see if, come on, keep putting, see? You'll be surprised to know that we got very funny pins. Dr. Praveen. Praveen is smiling, thinking that.
Sometimes it is very difficult for anyone to get a delta wave. And some of the pathways don't manifest.
Show the
When
delta,
you
show the
have
delta wave.
This is the delta wave. So this is the delta wave. It's nothing but a uprise from the baseline. There is a normal baseline which indicates that it directly catches a conduction system. So here it does, in between, it goes away from the AV node and it attaches to, the pathway attaches somewhere extra in the muscle. So you have a positive wave. So this is the delta wave.
So there are people who are putting it down, so they're actually hypoglycemic. So that's why the delta is below the ECG. So we can.
This is called, when you have something here, this is called intraventricular conduction defect. This is called IVCD. You can have a splintered QRS. Whatever happens later is inside the muscle.
No, we Dr.
This
Praveen.
happens much before.
Dr. Praveen, we were talking about those points below the ECG. Those 3 ones below that.
That's it.
Yeah.
What I mean is, suppose
He doesn't
you
like my
have-
jokes.
That's why it's called as a pre-excitation. It's called a pre-excitation because it happens before the ventricular excitation. That's a pre-excitation. So you are pre-exciting the ventricles.
serious.
So that's why whatever happens is just before the QRS. Whatever happens after is called intraventricular conduction.
Yes. So, yep, that's the delta wave. Okay. Okay, so this is a 45-year-old guy with CA pancreas, sudden dyspnea and hypoxia. What could it be? Simple one. So it'll come up again, I think. So you saw the ECG, you saw some T-wave inversions in V1 to V3. It's still there on your device. I'm seeing a little bit of a tachycardia, hyperkalemia, anterior STEMI, pulmonary embolism, pneumothorax, CA pancreas, 45-year-old, something which Dr. Sandeep discussed. Everybody's voted correctly, pulmonary embolism. A few words, Sandeep, there.
So the S1Q3 T3 pattern that was shown, I think you realized the pattern.
Yeah.
Even though it is not very sensitive, it can sometimes be specific for an acute core permanent scenario.
Correct,
So
correct.
this is the S1.
You can use my stick, which I
T3.
used. I bought it yesterday.
S in 1, the Q in 3, the T in 3. It is
Yeah.
not seen for all pulmonary
And you can
embolism.
show the RV strain. You keep using the stick, yeah.
This is the RV strain pattern seen in the V1 to V3 leads.
Yeah, so apart from the anterior wall, the RV is also manifest on the surface ECG at V1 to V3. So the RV is the most anterior. Obviously, the anteroseptum comes over there. Just on top of that is the RV. So if RV something happens, it'll come on V1 to V3. If RV is normal, anteroseptum also comes, that will also come in V1 to V3. So you should understand that anatomically both are sitting right there. V1 to V3. So that's why V1 to V3 is important. So anterior anteroseptal changes will also come there. RV changes will also come there. So that's the take-home message in this particular ECG. Okay, I'm going to skip the leaderboard. Suspense. Okay, 52-year-old severe chest pain. What best describes this diagnosis? Okay, so we can have some time to look at this. So I'm seeing some ST elevations in inferior leads. Yes, and some changes in V2, V3. Okay, that should be easy. And let's see the question. What is the question? What best describes that particular ECG? You can still look at your device and find out the answer. The answer is anterior MI, inferior MI, infraposterior MI, lateral MI. What best describes that particular diagnosis is the question. So we learned in my talk about how to look in an inferior MI, what else to look for. The correct answer is infraposterior MI. You saw, look at V2 to V4, whereby you saw, I said R is up, T is up, and the ST is down. So that's how it looks in a posterior wall MI. You know? So you have a flat ST down, R is up, T is up. You know, just keep that in mind. Okay, I'm going to skip the leaderboard again. A 40-year-old businessman, okay, routine checkup, what should be done? Okay, so I'm seeing some changes there in V1 to V3. His routine checkup, again, so he doesn't seem to have much of symptoms. What should be done is the question. You saw the ECG, it's still there in your device. He comes to you for an opinion. I'm seeing some things. You call for an emergency angioplasty because of the ST changes. Arrange for emergency thrombolysis. Do nothing at present. Send for cardiac MRI. Dr. Praveen will answer this question. What we're going to do in that particular patient. A lot of people answered, send for cardiac MRI. A lot of patients do nothing, which is the correct answer. And yes, Dr. Praveen.
Of course, if they are asymptomatic, you need not do anything.
First, just tell us about this pattern.
It's called as pattern because there's a ST elevation in the V1, V2, right oriented.
Sandeep can
the
show this.
rapid is downwards T inversion. So RBBB pattern, RSR dash,
Yeah.
RBBB pattern
Yeah.
with an ST
Elevation.
and followed by a T inversion. This is the Brugada pattern. This pattern is called Brugada pattern. Pattern is not the clinical syndrome. Well, to have a clinical syndrome, patient should have some symptoms and the clinical congruent, like ECG pattern, symptoms like syncope or palpitations or anything, which then you call it as a Brugada syndrome. Suppose there is a VT recorded, then it becomes a clear, typical Brugada syndrome. Just as this pattern doesn't mean anything.
So RBBB, ST elevation in that
T
typical look, it looks like that. So can it be anterior STEMI? Is
It's a
what somebody's
differential
asking.
There's a differential diagnosis of right ventricular infarction and STEMI, but then there are many differential diagnoses. You don't get the typical evolution pattern.
Yeah.
It be the same. It can be evanescent over time, but the pattern, whole thing disappears. That's the difference between an MI. In MI, there is a noted progression, like ST comes down, T, then T.
Evolution pattern.
That evolution pattern will not be there in Brugada. Brugada, it just disappears. It's also evanescent. Next day, the ECG will be normal. This may not be seen. So that disappearance will never happen in an MI. That's the difference.
And RBBB, yeah, sometimes you can see the QRBBB in anterior wall MIs. Okay, fair enough. I'm going to skip the leaderboard again. Last couple of more questions. 57-year-old with burning chest pain. What does the ECG show? I'm seeing something. Dr. Sandeep discussed this in his talk. Burning chest pain, some ECG changes are happening. What does it show? These are all revision, but very, very important, clinically relevant things. I selected this because I want this to be taken home, driven into our as a take-home message. So LVH with strain, anterior STEMI, lateral ischemia, inferior ischemia. Dr. Sandeep will dwell upon this, people are thinking. So this is something which you're going to see daily in your clinical practice. And to figure it out, so LVH should say everybody is correctly answered, but there are few people who have thought about anterior STEMI. Sandeep.
So this is a standard LVH with strain pattern. In this scenario, you should think of aortic stenosis, anything that obstructs the LV or strains the LV, which could also be severe hypertension. Sometimes in hypertrophic cardiomyopathy, coarctation of aorta, we can see tall R waves in V5, V4, V6, deep S waves in V1, V2, V3, and the strain ST depression kind of pattern.
What about that ST elevation V2? That's what's confusing them in V2.
That is just the strain pattern seen in V1 and V2. It is not, it's a coving type of.
It's the correlate of what we're seeing in V6. The opposite of V6, which is depressed in V6, becomes elevated in V1, V2. Fantastic. So that's a very important take-home message. The leaderboard I'm going to skip for suspense. The last 3 questions is getting exciting. And we're going to have a lot of prizes. Which of the following is a normal response in a treadmill testing? Normal, rapid upsloping, slow upsloping, flat ST depression, downsloping ST depression. Which of the following would be normal amongst these 4? Rapid upsloping, slow upsloping, flat ST depression. Okay, so a lot of you got the correct answer, but unfortunately there are a lot of people who got the wrong answer. So we said that if there is an ST depression, but it's rapidly upsloping, it's okay. But the flat ST depression, or it's going down sloping, that is very ominous, and that is significant of this thing. So this is how it looks like. Could you show Sandeep the rapid upsloping, the second ECG? Yeah, that's okay. Yeah. So, the normal one, yeah. So that's a rapid upslope. The abnormal is a slow upsloping after 80 milliseconds. It goes there. And the first one shows the flat ST depression.
Flat ST depressions and the downsloping.
Downsloping. So those are the ones which is abnormal, right? Okay, and I'm going to skip this because we're going to have suspense. The last two questions, everybody get set. Last two questions. About a patient with tetralogy. Nurse says that she heard a 3/6 systolic murmur. About 15, now the murmur is silent. Your reply. There was a murmur, now it is silent, the kid. You do not worry as the murmur is softer. Nurse made error. A TET spell is imminent. We may evaluate the patient by the end of the day. Okay, so the correct answer is a TET spell is imminent. So the patient can go for a pulmonary spasm, pulmonary stenosis spasm, and go in for becoming really blue. The murmur disappears because of very decreased flow across the pulmonary valve, and that's how a cyanotic spell happens. So you need to be really concerned about that. Dr. Renu unfortunately just left us. So that is the answer for that. So the leaderboard is, we're going to go for the last question, and then I'm going to go for the final answer so that we all know who actually is going to be winning. So it is suspense time. Identify the person. Okay? We all have these difficult questions coming up. Look at your device if you have some confusion. And so it is Kunyamad Koya, Pakar Koya, and Mamu Koya. So you can answer which of these is the correct answer. Everybody has voted very early, and so there are a lot of Kunyamad Koyas and Pakar Koyas also. And to get the correct answer, and those guys, those 6+1 guys have low sugar levels, and they're waiting for lunch right now. Okay, and we have the final leaderboard, I think, which is coming up, and to find out who is the winner of our quiz today. A lot of things are going to, the computer is going to reorganize. Prasin Pradeep is the winner of today's quiz. So doctor, so we're going to, I really hope we have, and you enjoyed our quiz. So we're going to give some prizes, Dr. Devika, Dr. Mohan. I request Hamza sir, our director of hospital, who's been patiently listening to all our, to distribute prizes to our champions. To the first prize, I call Dr. Prasin Pradeep. Yes. Get it. No. Okay. Okay, for the second prize, I would like to call Dr. Mohiddin sir. Please come with us on stage. Dr. Christo with 15,532 points. Fantastic. Dr. Christo. Great. Sir, no. Well, third place we have Dr. Ray. Oh, you're Ray? Okay, you're Ray. Okay. No, I'm not going to give a prize. You stay there. He's with me. No. You're not going to get a prize. No. Okay, Ray is him. No, you're not going to get a prize. Okay, I'll see the next prize. Let's see the leaderboard. That's cheating, huh? Okay, let's see. So, Dr. Yamuna. Anthony Jason. Dr. Yamuna, one more. No? Please. And last, fourth prize for Dr. Anthony Jason Augustine. The quiz is calculated based on the fastest and accurate. So the algorithm goes for accuracy and speed. Hamza sir, no? Dr. Hamza sir or Praveen, yes. Please, photograph. Thank you very much. That is great. Thank you, Hamza sir. Okay, last thought. In conclusion, everybody can just type in some words, what they thought about our CME, 1 to 2 words, type it in. We're going to wrap up. I'll present the vote of thanks. It's really gives me immense gratitude. First of all, to all the doctors who have come in here today to attend. We have delegates coming in from down south as well as up north. Thank you very much. A big shout out from all of us here in the Department of Cardiology. A big thank you to all the team members who supported me from behind, the BD team, in our hospital by Siju, Vishnu, Nidin, Sujin, all of them worked really tirelessly to help us here. The IT team, Babu Etan and his team helped us a lot in arranging all of these things for us. The F&B team who has organized the lunch which is coming up for you guys. My colleagues in my department, my senior consultants and my whole team which is sitting there, all of whom cannot be named. Guys who have helped me in my core issues, my managers, Shamjit, Wani, my core team members, Preeti, Millie, Sharija, Afsal, Anthony, Sheba, Ashwadi, Vidil, Justin, Kamalatan, everybody. A big round of applause to all my team members. Lastly, also to the management of our hospital, who has been very supportive. Hamza sir is there representing, and Mr. Lukman just left us. Also, a shout out to Sun Pharma, who helped us in organizing a little bit over here. Thank you very much once again. Looking forward to meet you all in the next year for Back to Basics. A small shout out here. I'll be planning an ECG masterclass next month, which is something which we had done around 3-4 years back. It's going to be a sort of a local thing. It's a 2-month course, once a week session every week for 2 months, which will wrap up the whole concepts on ECG. Mostly will be suitable for people within Calicut. You can put in your opinions if you would be interested. People in the groups will get information on that. Once again, thank you very much for attending Back to Basics Session 6 from all the team members from Team Cardiology, Aster, MIMS, Calicut. Thank you very much. I invite all of you for 2 things. One is to the certificates are available at the counter, at the registration counter. As I mentioned, we have 1.5 credit hours from KSMC. After that, you can all proceed for lunch, which we have organized in the ground floor in the executive canteen. All our team members in the back will help you, guide you to get there. Thank you very much. Bye-bye.